All right, everyone. So this just a quick recap. We were discussing about pelvic floor muscle. So this is a pelvic bone, pelvic floor muscle down there, and pelvic floor muscle is a group of 15 muscles which is arranged into this area from all the way starting from pubic symphysis to coccyx and both history tuberosity. It is a diamond-shaped muscle which is arranged there into 3 layers, and each layer has a specific muscles, and specific muscle has an important and specific function also. So this pelvic floor is now you can divide into 2 triangle. Upper triangle is a urogenital triangle, lower is an aneurysmal triangle. And beautiful pelvic cavity is formed. And into this pelvic cavity, in a female body and male body, we have some important organs are resting. Just behind the pubic symphysis, bladder is there. Then in the middle, uterus is there, and posteriorly we are having rectum. They both 3 organs are having their canals, and the canals are passing through the pelvic floor muscle. So this is the normal again arrangement of your organs into a pelvic cavity. And all 3 organs are having these canals, and canals are passing through the pelvic floor. So we are just understood that many issues can be there in our life which can cause a dysfunction of pelvic floor muscles. Important is like the weight, extra weight, wherever weight is falling during pregnancy or during obesity, obese people. So there's always extra weight is over the pelvic floor. So loaded pelvic floor. So this is the first cause. Second cause can be, you can understand any activity where we are increasing the valsalva. So that can be the second, when you are lifting the weight, or when you are like coughing, you are sneezing, you are holding your breath, or you are jumping. So those kind of activities are there where they are increasing the valsalva. And weightlifting. Third is any exercise when you are gonna do overuse of this muscle, too much of use. So urinary frequency is high, or sexual frequency is high, or like some kind of like irritable bowel syndrome and diarrhea is going on. So those kind of conditions can also create a more frequency of use to that particular area. An activity which has a role where we are going very close to the gravity. So gravity can also keep pulling it downwards. So strenuous activities, high jumping, or those kind of activities like can also create a weakness into the pelvic floor when you are getting too much of laxity into those muscles. Important hormones, which is also important, which is also playing a role, like estrogen is a very important hormone. Till the time we are into our reproductive life, muscles will be always strong. Our whole body will be always strong. They have the effect of this muscle. Relaxing hormone is the one hormone which is going to come during the pregnancy. So pregnancy is again a big factor. So all the females, we are going to get pregnant, and during the pregnancy, relaxing is going to create a laxity of this. And after pregnancy, then the baby is coming out from the vaginal delivery. So vaginal childbirth is also one, labor actually is a one phase of our life where the baby is going to pass by crossing this uterus and cervix. Baby is going to come to the vagina, and then it's going to cross these muscles. That is a door. These muscles are the door. So they will cross this door and come outside. So muscles can go for a lot of wearing, tearing also, and a lot of laxity can also be there. So these are the important causes which can create a problem. Other causes can also be there, the psychological causes. Like, because when we're talking about this particular area, so we have this area is present at, these muscles are present at a sensitive area. So whenever something happened to us, any kind of fear is generated, any kind of stress is there in our life, so suddenly the whole body muscles are gonna go into that kind of protective this pelvic floor, which already have some kind of tone, extra tone. So these muscles, under the fact of extra stress and fear, will always adapt and will prone to have more tone. So that can also, fear can also affect these muscles. And whenever you are holding tightness anywhere in your body, this muscle will always activate. So this is the second thing. And sexual abuse, any kind of abuse or any kind of bad touch, which we are saying someone will do with us. And so the female will not like it. And when she's not liking the touch around that area, again, the muscles are prone to create that kind of protective guarding around that area, and muscle can generate the tendency to develop spasm into that particular pelvic floor. So these are the simple important conditions. And like socially also, the acceptance of this part, private part, or this particular region is always kind of somewhere negative. So that can also affect psychological, how we are accepting our private areas and how much educated we are about our private areas. So according to that, how much care we are taking, that can also affect our pelvic floor. So these are the reasons why the pelvic floor muscles can get weak and can get even tight, hyper. So not only that, some pathology which is situated, the organs which is situated inside, if something happened with the bladder, something happened with the uterus, or something happened with your anus or your canals, any inflammations, any infections, any trauma, any like anything like, which happens, which can create some kind of problem with your organs, can also give a referred pain to your pelvic floor, or refer tightness to your pelvic floor muscles. And that can be the source of hypertonus pelvic floor. The fascia can involved. And if those those organs are like they are holding, the organs are holding there with the help of some important ligaments, and because of any reason, like during pregnancy, the relaxing hormone is going to come and create a lot of relaxation into the ligaments. If the healing is not good in postnatal time period, so might be loose and legs and saggy ligaments are there, which can unnecessarily start displacing, which will not able to maintain the positioning of the organs, and organs can start coming downwards over as per the gravity. So that can be a cause which can put a loading over the pelvic floor muscle. So these are some important causes which can affect our pelvic floor. Now, before proceeding ahead, when we are talking about the causes and which conditions we as a pelvic rehab therapist can help, any conditions where bladder is involved with the pelvic floor. So something can happen with this organ, and urinary, it can give some kind of urinary problem. It can be the frequency is high, it can be the urgency is there. So those kind of issues with the bladder and urethra. And second is anything happen with the uterus or around the anus. So that can always have this effect to the pelvic floor. And even pelvic floor can also affect the organs. So they are they're correlated with each other. So in today's topic, let's understand what kind of conditions can be a part of, can give you bladder dysfunction, or your sexual dysfunctions, or your bowel dysfunctions. To go ahead, it is important to understand the organs first. So let's understand our first organ, bladder, and then problems, conditions regarding with this bladder. We will also understand this. So one by one, we are gonna go through that. I'm sharing my screen with all of you. So pelvic floor dysfunctions can be sphincteric, supportive, sexual, visceral, sensory, pelvic stability, or circulatory dysfunctions. We know that these organs are passing, these canals are passing through the pelvic floor muscle in a female body, and these are the two organs which is situated in a male body, bladder and rectum. And in male, you can also appreciate that just below that bladder, they are having another important gland, prostate, and urethra is piercing through the prostate. So in male, this whole one with a penile structure on one urethra, or this passage is doing the both functioning of sexual organ, ejaculation, erection, ejaculation, as well as the functioning of urinal. So sexual and urinal both are done by this particular one organ. And in female, we have a different two structures. One structure is for urinal structure, and one is for all reproductive system. Every month we have this kind of periods coming out, or pregnancies going on. So this is and sexual intercourse is also going on. And this is two separate important difference between male and female cavity. But the rectum and anal canal is completely same in both. So let's understand the first organ, pelvic bladder actually. When we're talking about the bladder, so I want to first show you this one. I want to show you this one. It's like a human-sized bladder which is present just behind the pubic symphysis. And I want, like, if you'll see this bladder, so okay, so it is having one apex, it is having one posterior wall, it is having one superior surface, it is also having one inferior lateral surfaces. So this is the inferior lateral surfaces of this bladder. So two parts are there. One posterior wall is there, and one superior wall is there, and one apex is there. So these are the structures which is present. Apex is behind pubic symphysis, and this posterior surface is when it's just very near to the anterior wall of the vagina. And now, if I'll open this organ, so you can see, I'm opening it. Okay, so you can see this organ is again. Okay, so this organ is again is having this kind of different walls. Can you see over here? So we have a different layers inside. So outer layer, so there are 3 layers of this organ. So outer layer is peritoneal, like all organs are having their protective and peritoneal cavity, which is separating them from the other organs. And then middle, if you can see this red color of line everywhere. So this is one important muscle of the bladder, which we are calling it as a detrusor muscle. So this is the detrusor muscle of this bladder. And very inner to detrusor is made up with the smooth muscles. Okay, very inside you can see another layer is present, yellowish color. So this is a mucosal layer of our bladder. So there are 3 layers: peritoneal, detrusor, middle, smooth muscle, and more inner mucosal. And it's like a sheath which is all around. And into this internal, there is a like special property of this organ is that it can expand. It has expandable property, so it can expand. So whenever filling is going on into the bladder, so it will start expanding, and when we are going for emptying, it will again contract. I will not say that the organs walls are touching with each other. Bladder is not touching with each other. It's like a hollow organ. So into this particular, whenever the feeling is going on, all these 3 layers will go for expansion. And whenever contraction is going on, we know that contraction is there because of the detrusor activity, but all the structures, peritoneal will also contract, inner area will also contract, so complete bladder will contract and complete bladder will relax. So this is a special quality of this detrusor muscles, contraction and relaxation. And this an inner muscle, if you'll see the whole inner side muscle, so you can also see some kind of ridges are present here into that. These ridges are like we can say it's like umbrella like sacs. These are everywhere. You can see if I'm just rotating it, it is present everywhere excepting the posterior wall. So these ridges are not present at the posterior wall. Otherwise, they are everywhere. Okay. So posterior wall, the lower part of the posterior wall. Now, if I'll bring it very closer to you, so as you think that these all are the ridges. All these ridges, we are having stretch receptors are present into this area. So it means we have some kind of flat area present at the posterior aspect of our bladder. And into this flat area, ridges are not there. And you can also see that in this flat area, if ridges are not there, the nerve receptors are not there also. So they will not send signal to the brain if the urine keeps only, it will only stay into this wall. And if it will leave this level, it might start sending, if more than this, like it will start touching this sex, then they will start sending the signal to the brain, depending upon how much stretching is going on. So this is very important structure which you have to focus. And in this, everywhere anteriorly, around the apex, the sides, everywhere the layer, mucosal layer is present. It's only the posterior side is not present. So you can also appreciate there are 3 openings are here. 2 openings, one is from here, one is from here, and one is going downward. So these are the 2 openings from the ureters. So these are the ureters. right and left ureters. So from the kidney, ureters are coming and they will attach into the posterior wall. So you can appreciate the structure in the way that on the top we are having this. So from the both side of your uterus, the ureters are coming downwards and they are attaching with your bladder. And these ureters are prone to have injuries whenever some surgeries is going on with the bladder. So during the C-section. So some accidental injury can happen into this particular area. So okay, now in this particular structure, again we can appreciate that like posterior wall of our bladder, and we have these two openings, which is their uretral opening and uretral orifice, and one is this opening, which is the opening of internal opening of your canal, urethra. So you can join them together, and this is the structure which is forming trigone-like structure. Into this trigone structure, that this mucosal layer is not present. It's a flattening area. And into this flattening area, always we can understand that the stretch receptors are not present into the trigone. Stretch receptors are present in the upper side. And it means that whenever we are having urine here, that urine will not get that sensation of that urine. And even whenever we are urinating, after urination, till the time all this urine is present into this upper side mucosal layer, they will keep sending signal that we have a urine. But once that urine will be completely passed out, gone out, then it will be kind of there will be always no sensation. Still, some urine will stay here. Normally, 50 ml of urine, and this is what we are calling it as a residual volume of urine is always there. And we don't want collapsing of the structures or this whole organ. So urine should be always there into the trigone. And this is the behavior. Again, it is a holomuscular organ, and which has a capacity of holding. So this stretching, how much stretching the bladder can do, depending upon male and female. Female is having a smaller bladder size as compared to male, because male has more space there. We don't have that much space. So we cannot get that much of expansion, but our organs are still smaller than as compared to male. So our bladder can expand and accommodate approximately 400 to 600 ml urine. And male, they can always expand, they can always accommodate more than that, 150 more than that, they have, because of the bigger size. So this is the special quality of our bladder. And it is a holomuscular organ. When empty, the bladder is about the size and shape of a pear, and it is lying into the pelvic cavity. And when it is full, when it is accommodating some urine, it will always go towards the abdominal cavity also. And suprapubically, if you palpate yourself, you can feel that expansion also, as well. So we understood we are having 3 openings, and 2 from ureters and 1 from urethral internal meatus. And it is lined by 3 layers: outer peritoneal, middle intrusor, and inner mucosa. Function of this bladder is very, very clear now. It is gonna accommodate urine and store the urine. It's like a reservoir. So urine is keep coming from the ureters, and it will keep holding that urine for longer time period. And another important structure which is here is the role of urethra. So this is urethra, which is internal opening of urethra here, and external opening of the urethra is here. Now this internal opening actually. So this opening of urethra, internal opening, is always closed, and internal sphincters are going to play a role into that. It will when the brain will send a signal to the urethra to relax. So this internal sphincter, which is present all around this area, they will automatically relax, and urine will keep coming downwards. And whatever pressure was made, because that pressure was sending a signal that we have to go empty, so that pressure will go downwards, because some urine level will go into the urethra. So we have this internal opening, and around the internal opening, internal sphincteral action, internal sphincter is also present. That is again made up of the smooth muscle. So whole this detrusor extension is it is like a detrusor extension. Now, when we are talking about after the emptying, as soon as we empty this urine, so this whole ureters every 10 to 12 seconds, ureter will keep bringing that urine into the bladder. So in 10 second, 12 second, this side urine will come, other next this side urine will come, again this side urine will come, again this will come. So this way the filling will keep going on, keep going on, keep going on into the whole bladder. So once the half of the bladder will be filled up, and then like you can understand the level of this one, level of so more than this, so this is the posterior wall, and the level more than this, upper than this ureters. So about this one, it is already filled up, but it will start filling more than this particular level. So then it's gonna relax. It's gonna send signal. It will touch here. Once it will touch here, it will send a signal to the brain that relax. So at that time, brain will again send the signal back to the detrusor muscle, and detrusor will go for relaxation. More bigger it will be, so more relaxation will happen. So they will try to accommodate the level within this downward side, this particular at the level of ureters. They will try to accommodate that. So there will be one time when your bladder your detrusor cannot expand more than the particular level. Okay, so then it will again send a signal to the brain that, oh, go and empty. So, but this is the first signal which we will get. There will be always two signals the brain is going to give you. That is a sensation that my bladder is filling, or I have to go for urination. The first signal, and if you are avoiding the first signal because you are busy in something else, so again the brain will automatically open up the internal sphincter and some urine will go there. And then the pelvic, because you are busy in some other work, so then external sphincter muscles will come and they will try squeezing here. So if they will squeeze here, so because of the pelvic floor muscle squeeze, urine which was there into the urethra, that urine will push back towards the bladder. It will come upward, and because of this compression by the pelvic floor and squeeze, they will not go for relax. They will maintain the tone, and the urine will come upwards. And if it is coming upward, it means that female don't want to go for urination, or male don't want to go for urination. It means holding is still required. So for that, again, brain will send a signal to that internal whole organ, okay, relax. So again, whatever capacity of this organ will be, it will expand. It will keep expanding. But that is the extra expansion of the bladder is going on. So this is what we are calling that we should not hold urine for long time period. When you are holding urine for long time period, you're not going for voiding, your brain is sending you signal again and again, but we are keep loading our bladder, we are keep expanding the bladder, that the detrusor is relaxed, the stretch receptors are stretched out. So you are overusing your bladder wall, your bladder muscles. And not only this, you are using that, the compression will be always downward into that because internal sphincters are already open. So pressure will be always on your pelvic floor muscles also. So you are doing the weakness of your smooth muscle, as well as we are doing the weakness of our what we are saying is external sphincter muscles, pelvic floor muscles. They will be loaded, overused. So this is the behavior of our bladder. Now, when we are talking about this micturition process, so this, like the function of this bladder, so there are two functions of the bladder. First is working as a reservoir. It will keep filling the urine here. And after that, it will help in emptying. So the whole bladder, so it is expanding also, detrusor is expanding also, and detrusor will also play a role into emptying. So once you want to, you will go for urination. At that time, our detrusor will start contracting and will do extra contraction, because whatever maximum amount is there, which is putting pressure over the stress receptors. So as per this signal, the sensation, it will keep contracting, and try to like move all the urine fluid out from the this part, the pressure, but the area which was touching the stress receptors. At the end, some urine will be left, which is present into this trigon, and that is approximately 30 ml to 50 ml. So we should not have more than 50 ml. And if it is more than 50 ml is there, it means you have a relaxed bladder. So it means bladder action is somewhere altered, or it should not be even lower than that. If it is lower than that, it means your muscles don't know how to relax. Your detrusor don't know how to relax. So again, it's the bladder pathology. So this is the behavior of your bladder. Now, what happens during the urination? If, as I already told you, what do you want to do? You want to hold or you want to pass? So first, brain is keep sending you the signal that go for urination. And you are not going for urination, it means your pelvic floor muscles will keep contracting. Once you are, so what is going on at that time? Urine is coming, bladder is relaxing, it will keep relaxing. One stage will come, it cannot relax more than that. Okay, internal sphincter will open up, urine will go downward. Suddenly, pelvic floor muscles will come and they will start contracting, because we don't want to pass the urine on the same time when the sensations are there. Right now, we have a sensation, but we need some time to go to the washroom. We cannot pass on the same time. So our pelvic floor muscles are a voluntary muscle. They will contract like this. So they will contract it. After that, and then once they will contract, again, they will stimulate the detrusor muscle to relax further, and it will keep loading the bladder. And this is what the feeling is going on, more feeling inside. Now assume that now we want to go for urination. So for urination, what we want, we'll get the signal first. As soon as the signal is there, then we'll walk to the washroom. We'll lock the door, we'll sit down, we'll take a position. In that position, what we want to do first is relax the pelvic floor muscles. So pelvic floor muscles of this external sphincters, which was all around this, they have to go for relaxation. So as soon as we'll sit down, so we are giving a command to our body, okay, I want to pass. So signal is going, automatically our pelvic floor muscles will start relaxing. The first muscles which was holding it, pulling it towards the pubic symphysis, is trying to close the upper orifice door, upper side door. That was a pubourethralis muscle. So this muscle will first relax. And once that will relax, the angle will be there and urine will keep falling towards the urethra. And then the external sphincter, this urethral sphincter compressors, the middle layer, they will be relaxed. They will release the pressure. So first the kink will be there, deeper pubourethralis muscle will relax. Then the second one, compressors will relax. And slowly urine will come outside and bulbo will also relax. Urine, now there is no pressure over the urethra. And now it is whole urine, whatever what was there, as per the gravity, it will start falling downward, because we are also taking some positions, gravity assisted positions. So we don't have to strain unnecessarily. So as per the gravity, it will keep coming outside. As soon as the whole uterus, the bladder, the urine will come out, after the end, our detrusor will create a contractions. So urine is still flowing and detrusor will start contracting at the end. Whatever extra urine is there, we really want to move them up outside. So then detrusor will start contracting like this, and they will help in emptying the urine. After this, they will squeeze like a balloon, and urine will be like you are squeezing lemon. So lemon will be squeezed and the drops will come outside. All the drops will keep falling from the urine, from this bladder, it will come into the urethra, and from the urethra, by passing through the canal, it will come outside. We can see that now it is, urination is finished. As soon as the urination will be finished, so what will happen? First, the upper urethra has to close first. So into the urethra, the levator ani, which was up, it will create a kink, because now it's done, urination is done. So first, this pubourethris muscle, which was holding it, it will pull the urethra towards the pubic symphysis. Second, whatever urine is there into upper part of this canal. So this has happened, this first kinking. Second, urine is there, so that urine should be squeezed. So compressor will create a pressure and they will create a squeezing effect. So whatever urine is there into the urethra, it has to come outside. So they will squeeze, and after that pelvic floor muscles will close. As soon as this complete external urethral sphincters are compressed and closed again they will maintain a tone, whatever tone we are, it is our body tone. And then it is closing. After this, internal sphincter will close. As soon as internal sphincter will close, the detrusor, which was creating contraction, it will go for relaxation. So it will relax. And our bladder is again ready for filling. Are you clear?
Yes, please.
Okay. This is any question? All right. So this is our bladder. So sometimes some problem can affect either this filling phase or either this releasing phase, or might be the holding phase. Something can happen to your bladder, something can happen to our urethra, or something can happen to our pelvic floor. So there are the three things. And fourth is the nerves, which is supplying your bladder, urethra, and your pelvic floor. So all these nerves. So muscular problem can be there, nerves problem can be there, as well as the smooth muscles problem can be there, problem with your organs. So that can be the pathology and the condition which is affecting our bladder. So first problem, let's understand what can happen with this organ. Okay. Yesterday we were talking about interstitial cystitis, one problem, which is the problem of your internal, this kind of layer, the sheath, mucosal layer. Because of any condition, the mucosal layer is start getting infected. Some infection is coming into this mucosal layer. An infection is there, so it means what will be the sign of that? Inflammation will be there. So whole interstitial layer will be under the inflammation, and because of this inflammation, whatever this nerve stress receptors were there, they will send a signal to the brain, painful signal to the brain. And we also know that every 10 to 12 minutes, we have urine coming out from the ureters. As soon as urine will come into that, urine is acidic into nature. So that is going to give, and we have an inflamed structures, that is going to give burning kind of sensation, pain as well. So pain, burning, that kind of things will be. As soon as some amount of urine will come, it will touch the inflamed structure, and that will send a signal to the brain, I have pain, or that kind of burning, I have burning. So as soon as the burning is there, so pain is there, the signal will again go to the brain that pain is there into the bladder. Okay, then why the pain is there? Because of urine. So the brain will ask, create that situation that, oh, go and urinate. So the female will get up and she will go for, male or female, they both, they will get up and they'll go for urination. Small amount of urine was there, it's just a 5 ml, 10 ml, but that urine is irritating, it is giving them irritation inside, that kind of pelvic pain and bladder pain, that kind of issues. Now no expansion is going on, because once it cannot expand, all this internal structure is inflamed, and because of this inflammation, this whole, the surface area inside will be less also. So they can't expand the bladder, and inflammation is gonna give them the painful situation. Again and again, female will have, as soon as the urine will come, female will have a pain, she will go to the washroom and she'll try to empty. So the frequency of urination in this case will be very, very high. Even I have seen my patient 58 times going in a day. So that is very, very high. Every 10, 20 minutes, they are going to the washroom again and again. You can understand that why it is going on, because of this inflammation. So into this inflammation, you can also understand how it is going to affect the urethra. Inflammation, this is all urinal system, urethra is there, inflammation can happen to the bladder, and from there it can go towards the urethra. And if urethra is inflamed completely, our pelvic floor muscles are touching that. So pelvic floor will also get hyper. Okay, that then we also get this kind of tension into the pelvic floor because of this inflammatory changes will be into the pelvic floor, and they might fail to relax also. So patient will also have a burning as well as difficulty in passing because they will not get relaxed. So difficulty in passing the urine. So all structures can come one after another. So this is interstitial cystitis. There can be any cause of interstitial cystitis. It can be inflammation because of some infection coming out from outside, UTIs, frequent UTIs. Infection is into the urethra, then it is going to the this side, and it can be that infection can going towards the ureters also. They can go all this upper tract as well. So whole tract is infected. So urinary tract infection, we are calling it as. That can be a source of it. Or might be the inflammation is because of any internal pathology. So let's understand. I'll share my screen with you. The cause of interstitial cystitis will be, yes. So we understood that why this is whole inflamed internal layer. You can see inflammation. And that can be, it can happen because of the defect into the bladder epithelium. Some defect is going on, which can create irritation. Irritation to the bladder by some chemicals released by the body. Bladder trauma, some trauma can happen there. In seasonal, including any surgical procedure of the pelvis, any surgery was going on and that created some kind of trauma, and because of that, there might be infection. Bacterial infections, which can come from outside, and by doing this one, infected the urethra, and then infection is coming to bladder also. Body own immune system can also attack the bladder, or abnormal nerve activities can also be the cause of this kind of, they will not relax, they will keep contracting this area. So that all can be the causes of interstitial cystitis, creating the inflammation inside. The patient is going to feel pain into the pelvic area, pain into the perineal for male, feeling the need to urinate very, very often, urgency to urinate because the burning sensation will be there, which will make them to urinate again and again. Feeling pain while urinating, burning and pain while urinating, because your pelvic floor muscles can also be entrapped and urethra can also come into picture. Feeling a burning sensation when urinating, feeling pain during sexual intercourse. You can also understand the female will, during sexual intercourse, now male is having the their gland is here, prostate gland, so that can get inflamed. And female, we are having our vaginal tissues at the back. So when vagina will expand to accommodate the penis, that expansion will put pressure over from the posterior side. So it will be pushed anteriorly, and because of the squeezing, patient can have pain. 85% of the patient, 85% were found to have pelvic floor myofascial pain and hypertonicity into the pelvic floor in case of interstitial cystitis. So means pelvic floor will be hyper, actually tightness, painful pelvic floor, inflamed pelvic floor. So our rehab as a physios, after taking a detailed history and going through the diagnostic reports, we find out already doctor has referred the patient to you. He's suffering from interstitial cystitis and the frequency is very, very high. He's having pain. So what is our role here? To relax the pelvic floor. Whatever inflammation is going on with the pelvic floor, or tension going on with the pelvic floor, we have to relax that. So relaxation therapy, relaxation techniques, or releasing the muscles tension, tightness is our main goal, by improving the blood supply also. It might be the blood supply is, or the arteries which is supplying this pelvic floor muscles, they are entrapped. So you have to release the pressure from nervous system, and you have to release the pressure from this way, all these veins as well as the arteries, and relax the fascia. So this is interstitial cystitis, and we have 85% people will have a tight pelvic floor in this case. This is the first situation of our bladder. Second condition of our bladder can be,
Dr. Patel?
yes.
Can you please quickly explain once that why the pain during sexual intercourse happens because of the interstitial cystitis?
Yes. So now what happened actually, interstitial cystitis is, this layer is inflamed everywhere. So this is what our organ is. So this is inflamed everywhere. It means the posterior part will be also informed, the posterior wall, and because of this inflammation. And now what we are doing in sexual intercourse as a women, the penis will be inside, and as soon as once the penis will go, vagina will expand. Vagina needs some space, and that is gonna push the uterus anteriorly and rectum posteriorly. We need that expansion inside the vagina. So assume this is my penis which is going on. As soon as the erected penis will go, it will push from this anterior wall, it will push that anteriorly, blood anteriorly. And now another thing which is here are important sexual organ, the legs, bulb of vestibule, that is also coming from the sides over here from the urethra. So the bulb of vestibule, assume that this is the urethra, this is my clitoris, and both side over here. Now can you understand the G spot was going on the sides. So because of the inflammation into the posterior wall, the pain will be into the vagina, and because of the inflammation of the bladder, the pain can be there. Some inflammatory changes can be there into the tissues which is attaching which is coming in connection with this bladder, means our bulb of vestibule. So they can also get inflamed. So female can have pain, and as soon as you insert, pain during arousal also she can experience pain, and even during the penetration. When you penetrate, the penis will push it anteriorly, and because of the push, posterior wall will be pushed. So that is going to give stretching to all the nerves which was kind of trapped. So that will give her a painful sensation.
Okay. Yeah.
Ma'am, will you afterwards will you explain the nervous stimulation over there and muscle?
Yes. We are understanding the condition first, and then we will understand the assessment and then the treatment. All right?
Yes.
So this is the first condition, interstitial cystitis. Second condition, which is related to the bladder, is urine incontinence. These are the two conditions where we have a role. Or might be endometriosis. Endometriosis can also create a problem with your bladder. So what happens, in endometriosis, always endometrial wall should be formed inside the uterus. But that, because of some pathology, because of some different, like whatever is going on around this tissues, these tissues can start developing anywhere else in your body. So that tissues can develop around the uterus also, and that tissue can develop on the inferior part of the uterus, downward here, where it is going to come into connection with your bladder, this particular space. So because of this endometrial tissue, and every month they will go for shedding, every month the blood will start collecting here, they might start creating tightness or kind of grabbing, stickiness between these two organs. So it means if the stickiness is there and adhesion is there, the tightness, it will not let the bladder to expand superiorly because of the tension. So that can also affect your bladder behavior. Or sometimes endometrial tissues can go and start forming into the peritoneal cavity or myometrium, or inside here also into the bladder. So those endometrial tissues will grow every month, and every month, as per the hormones, it will grow every month. Even the bleeding will come out from your urethra. So that can also be a severe situation where your bladder is affected by the endometrial tissues. And that can again affect the relaxation of your bladder. So in this case, frequency of urination can be high, and there will be no that much pain, but tension will be there inside your bladder. Tissues cannot expand because of that size which is involved. And if the doctors will do surgery, laparoscopical surgery, they will try to incise those particles. After those incision, those tissues will go for healing, and the healing is going to create a scarring and kind of all adhesions kind of structures. And it means that area will not be that vascular. So that is going to affect your bladder behavior forever. There might be some tension into that particular sites from where they have incised this. So endometriosis can be one reason why the bladder can come into picture, and urinary frequency can be high. So in case of endometriosis, if the female is going more time, so we can understand that either If there is no structures are present inside, then might be some tension is going on the top of this endometrial particles. They are putting pressure. They are not letting it relax, expand upwards to the perineal body, abdominal cavity. Okay, so that these females can also have a high frequency of urination. Third condition of that with this can happen is urine incontinence, leakage of urine, which is very common. Like I will say 50% females are suffering from these issues after like menopause. I have seen more, male and female also, male also. And male after prostate removal of their prostate or those kind of situations, that age after 40 years, 50 years, they might have more leakage issues. Even kids, they can also suffer from this kind of issues. Now, what can be the source of urine leakage and what is urine leakage? Let's understand the urine leakage and the types of urine leakage. Okay. When we're talking about urine incontinence, means the person is not able to maintain that hold or continence. It is unwanted and involuntary leakage of urine. I don't want to leak urine, but it's coming outside. So why it is coming out? Why are my internal structures are not functioning well? So what is the pathology? So inability to control the urine is one of the most unpleasant symptoms someone can have. And the causes can be any problem with the urinary tract infection, any problem with bladder and urethra, your nervous system, or your pelvic floor muscles. Three things can come into picture. When we are talking about we are leaking the urine, we are not able to hold the urine. So what type of urine incontinence can be there? There will be always two types, two conditions actually. One is a acute incontinence and another is a chronic incontinence. Acute incontinence means something happened to your body, your urinal system, and that is a temporary, that is going to give you temporary effect. So, temporary, like you are under the effect of alcohol. We drink alcohol. So till the time the alcohol effect will be there, so my bladder and urethra will be relaxed. And might be that the pelvic floor muscles will also relax. So we can have this urine leakage. As soon as the effect of alcohol will go, so there will be no incontinence. So it's kind of acute, which will temporary. Actually, it's a temporary or something can be permanent there. So another one is the alcohol. Second, whenever we are taking some medication or some kind of a liquid, like for example, caffeine is there, intake of caffeine, something can trigger your behavior. It can be the Coke, it can be the fizzy drink, it can be your tea or coffee. Something is giving you the effect. As soon as you will stop that tea and coffee and those caffeines, the effect is not there. It means something was relaxing your structures, smooth muscles. Another is when we are suffering from some kind of those kind of other health issues, when we are admitted to the hospital. So during this acute illness, might be we don't have strength in our body to go and get up and go to the washroom. Our whole body weakness is there. So that can be one reason where we can have some kind of hospitalization is going on. Into hospitalization might be that they put some catheter on because we were very weak. So that can be like till the time catheter is going on, it will keep coming outside. Otherwise, after when we are completely fine, once we recovered, so now we can control. And some infections are going on because infection is there. Till when you treated the infection, now there is no problem. That can be the temporary effect in our life. Urinary tract infection can cause inflammation of bladder and it can create a spasm of the bladder and increased frequency, which can lead to the urine leakage or kind of increased urinary frequency also. So that can be one issue. Atrophic vaginitis, or urethritis. That is one thing, like as per the aging or those particular phases of our life when estrogen hormone effect is down, like during postmenopausal, postnatal phase, when our body is busy into production of this prolactin hormone, relaxing hormone is also there. Estrogen progesterone effect is not there. So in that case, Yes, there might be that vagina is the tissues, the skin, the tissue, mucosa, or the whole organ, smooth muscle is already lax or kind of weak structures are there. Thinning of these organs are going on. So if another thing which is important to understand that whenever we are talking about the bladder and the urethra, so bladder and urethra has supportive structure. Its supportive structures are some ligaments which is holding the bladder and which is holding the urethra, and those ligaments are coming from the pubic symphysis, and they will loop around the organ, this downward part of this what your bladder and your urethra. Pubo-urethral ligaments are there. Those kind of cystic ligaments are present in our body. So once those ligaments will be weak during the pregnancy, so that can be one reason that till the time you are pregnancy, your ligaments were weak, and that's why you are having those kind of not relaxed urethra and relaxed bladder. Or another important fact over here is that this whole bladder is supported by three things. The bladder is supported by ligament, which is holding them. It is supported by the pelvic floor on which it is placed. So pelvic floor muscles are also like this. So this ligament and pelvic floor muscle is a supportive structure. But another important supportive structure of the bladder is vagina. So once we are having bladder anteriorly, so what is present at the back? We have vagina. So if the female will have a good and strong vagina during reproductive time period, so means the skin of the vagina, the layer of the vagina, the smooth muscle of the vagina, it's not the mucosa of the vagina is strong, it's healthy. So that vagina will get that kind of tone inside. Tone will be always there, and because of this tone will be there into all the walls of vagina, anterior wall, posterior wall. So posterior part of the bladder and urethra is supported by anterior wall of your vagina, and that is going to give extra support to your bladder always. It will not let your organ fall backward. So three things are important here: ligaments, this anterior wall, it is also toned good, it's not like a saggy and lax vagina, so it is also toned vagina. And third is a pelvic floor. These three things is important for your bladder support. Just be with me. So these three things are important for our bladder support. So due to aging effect, menopausal time period, during pregnancy is gonna support. So during the pregnancy, the anterior wall will be pulled upward because uterus is expanding, and with the expansion of the uterus, anterior wall will also get stretched out. So it will try to maintain the pressure on the bladder. It will not let the bladder to fall downward because the whole vagina is swollen up vagina. So support will be there during the pregnancy. But in postnatal period, as soon as the baby will come outside, you can understand the whole relaxing hormone is creating some relaxed structure is there. Vagina will be relaxed, loose, saggy. Baby came out from that. So that vagina during childbirth also, there might be some problem, some extra compression over this, extra push stretching effect can be over your bladder. And another thing is even your saggy vagina is not strong and toned vagina into postnatal time period till the time female estrogen effect will again not come. So that the support will go. So that can be a reason why that prolapse can happen afterwards, after the childbirth. The support of the vagina can be down, and the support of the vagina can be down in menopausal time period. That will be the complete recession. Now there will be no periods. If there will be no period, there will be no estrogen. Estrogen level will be always completely down, and estrogen is going to create a lot of weakness into the vaginal tissues. Vulva tissue down there, pelvic floor muscles. So even your new studies are saying even our urethra is that urethral whole smooth muscle of urethra is also under the effect of estrogen. So estrogen is going to create too much of laxity and weakness into the complete urethra, bladder, as well as your vagina. So that the supportive system from the back will go. And if that will go, the bladder will start falling backward. So urethral prolapse can happen, or your bladder can start falling backward because the support is not. So I was like this. This chair was holding me, but if this chair is not holding me, I'll start sagging backwards. So this can be one reason of the prolapse in postnatal time period. So this is that, and that can be again be a source of weakness of your, like loading of your bladder towards the posterior wall. So it will keep loading and keep putting pressure over pubourethralis ligament, pubourethralis muscle. Because if something is pulling backward, it will keep putting strain over the pubourethralis muscle, and that can be the reason of weakness into the the central muscle, levator ani central muscle, pubourethralis, the central, and that can even stretch out the pubovaginalis and even stretch out the puborectalis also, the posterior pull of this organ. So weakness can be, and another three things are there, that vagina is also weak, pelvic floor muscles is also weak, and they're also under a lot of effect. So this can be atrophic with vaginitis, when vagina is atrophied, going through this atrophial changes. Urethra is not good enough. Thinning of vaginal mucosa and supportive tissue due to estrogen deficiency with increasing age. So that will not come into acute, actually, that will come into the chronic phase. But if this is going on during the pregnancy, so after the pregnancy, after the childbirth, relaxing hormone will come, it will become a healing hormone, it will heal the vagina, it will heal the tissue of the vagina, and even urethra also, relaxed bladder also. So in pregnancy is a one time which will come into acute, but postnatal will come under the chronic. Functional change in mobility due to some illness or surgery. We cannot get up from the bed and we are leaking because we don't have strength to move. Endocrinal disorder like diabetes and hypercalcemia, where you are taking those kind of antidiuretics or those kind of medications, which is creating the relaxation of your bladder and your urethra. Dehydration can also cause urine to become concentrated, which can irritate the bladder and cause leakage. Female, they don't want to go for, they're not taking enough intake of liquid is not there because they don't want to urinate. So that can be a cause, that can be one factor which can change the behavior in your bladder. So irritation can come, or might be unnecessary squeezing of that will be there. It's not expansion is going on because it is not feeling urine. There's no sufficient water intake is there. Some medication like antidepressant, anticholinergic, diuretics, we already discussed, beverages like alcohol, caffeine. So all this means something came temporary. So this is the acute leakage, or acute frequency is high, or acute sensation is high. Okay. So that can be the acute behavioral change with your urinal, whatever, the functioning of your urination. So that is acute. The second is, we are calling it as a chronic. Now it is a chronic illness. Patient is like, from last 6 months, I'm noticing that I'm not able to hold urine. And whenever I'm jumping, so there is a leakage, or might be there is a sudden urge is coming, and that is the symptom which is from last 6 months, and it's not just resolving. And so this kind of thing, when it is not resolving, and this like leakage and frequency, urination frequency and leakage is going on from long time period, and so we call incontinence. And that chronic, this incontinence is again divided into 5 types. Actually, there are 5 types of incontinence. One is a stress incontinence, when you cannot hold urine and urine is coming outside. Some problem is there. One is a stress incontinence. Second is the urge incontinence. Third is the overflow incontinence. Fourth is the neurogenic incontinence. Fifth can be mixed incontinence. So what is stress incontinence? Stress incontinence means that this is our bladder. So this is a picture of male. Actually, this is, you can see the prostate gland is present here. So now, how the arrangement is there in a male or female? This is the female body, urethra and vagina posteriorly, and we are having pelvic floor muscle all around. The support of the pelvic floor will be completely 100% of the urethra will be supported. So this is a female body, urethral support, external sphincters. And this is a male urethra, bladder. Urethra will start by piercing this prostate gland. It will keep continuing, and then we'll have, at the end of the prostate, we will have the pelvic floor. And then we'll start the body of the penis. And these are the legs of the penile structure. So this is the structures is present. Now, what happened during the stress incontinence? Stress incontinence, whenever our body is going under the stress, some intra-abdominal pressure is increasing. We are sneezing, we are coughing, we are involved into those activities wherever this Valsalva is increasing. So because of this abdominal pressure, the pressure will move that abdominal content downwards, and that pressure will fall over the pelvic content as per gravity, like as per this gravity also. So pressure will fall downwards, and the pressure will come into the bladder anteriorly, and because of the bladder pressure, then bladder will, the detrusor, the whole bladder which was expanding, which was kind of stretching, but suddenly the pressure will fall into that. So it means you are squeezing something from the top because of internal pressure. Squeeze is going on. So detrusor will get squeezed. And once detrusor, because detrusor was expanding, but it squeezed. As soon as it squeezed, now the whatever urine is there, that urine will pull downward because of the pressure. And that will put a pressure over internal sphincter, and automatically the internal sphincter will open up because of the pressure. And urine will come into the urethra. So this happens. This is a normal process when we are having this Valsalva. So as soon as the urine will come into the urethra, so at that time, our pelvic floor muscle should generate a reflexive action. So because I don't want to urinate, this is not the signal which this is not one thing which I want to do at that particular time period. I am doing exercise, I'm doing jumping. So my brain is not telling me, is not giving me, I don't want to go to the urination. This is not the feeling. My feeling is I'm involved in exercise, or I'm involved in laughing. I'm engaged with some other thing. I'm pushing something, or I'm pulling something, or I'm lifting something, or I'm coughing. So I'm coughing, I'm not urinating. So that is the other action is going on of the body. So when the urine will suddenly come down there, so body, brain has to send a signal to the pelvic floor, and pelvic floor has to generate a strong reflex. And because of this, instead of when the urine is coming into the urethra, suddenly the pelvic floor will go for contraction. And because of this contraction around the urethra, compressor will contract, and the kink of the pubourethralis muscle, that will also pull. Sudden pull will be there from the fast twitch muscle action from the pubourethralis. Suddenly it will pull the urethra anteriorly, and it will close the angle. It will not let the urine come to the urethra by pulling this. And the second, compressors will also squeeze. So sudden action, fast twitch action is going on. And because of the squeezing, what will happen? Squeezing, when you are squeezing something, it means upward movement. So your pelvic floor muscles will do this squeezing and will create upward movement. So whatever upper movement was there, downward, that movement will be counterbalanced by this pelvic floor muscles. They will squeeze, and they will again move the urine upward, and they will relax the detrusor muscle. So this is a right behavior, but that behavior comes once we have a strength in our pelvic floor muscle. So this is what we are calling it as a trampoline effect of the pelvic floor during the Valsalva. So stress came, urine came downward, detrusor squeezed, urine came downward, internal sphincters open up, urine came into the urethra, suddenly pelvic floor created a reflex, and squeezing, urine moved back upward. So trampoline effect. So this should be the normal. But if the patient is leaking during the sneezing, it means what is not normal? The squeezing effect is not there. It means the pelvic floor muscles are not strong. Some problem is, 100% problem is the pelvic floor muscle in case of stress incontinence. So those patients, we are the solution. Doctors cannot, the urologist cannot solve this problem, stress incontinence. They have to send their patient to the pelvic rehab therapist or physiotherapist, and we know how to create the strength into the muscles. Clear about stress incontinence? 100% our role is there.
Yes, ma'am.
Great. So this is the first type, stress incontinence. Now we can read also, because of increased intra-abdominal pressure, it is due to sphincteric dysfunction. That is a sphincteric dysfunction, pelvic floor sphincteric dysfunction, or weak pelvic floor. And that can cause some urine, suddenly some urine will come, and suddenly we will get to know, oh, urine is leaking, and we might stop the activity, or we might squeeze the pelvic floor by putting extra squeezing, of the pelvic floor. Will create a contraction, because the now consciousness will come into picture. But leakage can be there, and that kind of leakage can be in drops. As soon as the drop will come, we'll get notified. As soon as we are getting this signal, we might stop the activity, or we might squeeze the pelvic floor, and we'll try to control it. Or sometimes the leakage can be even into the more amount. More weakness means more leakage will be there. Less weakness means only drops can be there. Okay, so we have to again ask how much leakage is there. Okay, so when you are having leakage, which activity, how many times, and what is the amount of leakage? Amount of leakage is 1 spoon, 1 teaspoon. It means it's a big amount. More leakage happened, or it's just a drops came out. If just a drop came out, it means might be the muscle has some strength. But if more leakage was there, so it can be the sign of more weakness into the pelvic floor muscle. So this is the stress incontinence. Second type of incontinence is the urge incontinence, or we can also say the overactive bladder. Urge incontinence means that we are having sudden urge to urinate. In this case, sudden involuntary loss of urine because of detrusor overactivity, causing strong urge to void. Suddenly, we don't know what will happen. We were okay when we were doing shopping, but as soon as we started coming home, we started opening the door of our house, and it triggered something. Our internal behavior is triggered, and now we started feeling this kind of, oh, the urine, I have to pass the urine. So sudden urge comes. And that sudden urge can be there because of some kind of stimulus, some kind of sudden stimulations. So the stimulations can be anything. It can be even the sound of the water. It can be that opening of the door of your house. Anything can trigger your bladder to contract. And in these triggers, your detrusor will start contracting suddenly. So it means some pathology is there with your nervous system. Nervous system is involved into that, not the pelvic floor muscle. And because of the nervous system pathology and some problem with them, some weakness of the nervous system, also trigger to the nervous system, those nerves which is causing, which is all around the detrusor muscle, because the detrusor will suddenly contract. And automatically, so it will not even give us a signal to contract. We will not even get to know. We are having this urge, and we want to open the door. Urge is there, something is triggering me, contraction is there, it will come down into the urethra, internal sphincter will open up, it will come into the urethra. And if your pelvic floor muscle is strong, so urge is there, but you will not leak, because by creating this closing contraction, you will try to maintain the compression. By doing your extra action, you might squeeze your adductors, you might start cross your legs, like you might start jumping. You will do something to stop the urination. You are controlling. And then you'll walk to the washroom, and we are lowering our panty. You will sit down on the commode, and then you are passing urine. But the urge was there. It means pelvic floor muscles try to maintain it didn't let you leak the urine on the way of washroom. You manage them to hold. So pelvic floor muscle has a strength, but detrusor muscle is creating this kind of behavior. Detrusor is active, hyperactive. So whenever our patient will come to us and refer to us, and it will be written onto the this file that urge incontinence is this complaint. So the first thing should come in our mind is the only reason is that detrusor activity, or what is causing the detrusor muscle to act is a nerves. So it means nerves which is supplying the bladder, they are not functional, and some kind of impairment is there into the nerves which is supplying this particular bladder. We are not talking about the nerves which is supplying the urethra. I'm not talking about a pudendal nerve. I'm talking about the nerve which is supplying this bladder. So those pathology is there. And then the second, yeah.
Dr. Sunita, why do you think that would happen? What could be the cause of the nerves being affected with supplies that
It can be some during any kind of surgery, might be something happen. So it is very, very common after C-section. Okay, nerve injury to nerves which is supplying that, it can be one cause. Third, that training, what happens, a habitual pattern, how we are behaving since long time. So if you have that kind of always like, you are again and again, your frequency is very, very habitual pattern, like, okay, you are going for you generate that kind of habit that, okay, I'm going out, so let me urinate first, and if I'm, as soon as I come, let me urinate first. So you develop those habitual pattern, and because of that habitual pattern, now next time, as soon as you open the door, that is your brain is already trained in that way. The nerves will start contracting, and they will create a compression of that. Habitual pattern is responsible for that. Okay, and the damage to the nerves to that area. Two factors are there. So that stimulations. Another thing is, we train ourselves in some ways. Just a very simple, if I'll just give you an example, since child, when our babies in our hand, we are training them for passing the urine. So we don't want, as a mother, the baby is leaking on the bed. It's like, it might be 1 year baby or 2 year baby. So it's just a growing babies there. So what we start training, shh. So we create some sound, and every time this sound is a stimulus for their nerves to give a signal to relax. So those kind of signals, even the like is always there. That kind of training is always affect. The sounds can affect you. The sound of a water. So whenever the water is there, you might start having the water is falling. Your internal muscles the nerves can relax. It can give a signal to you to relax or start contracting, like to just for urination. I don't know how many of you experience this in your life, but I think 100% of you, all of you, that whenever we are going to the for the bath or for the shower, and as soon as water is touching our body, are we urinating at that time? Have you ever noticed this?
Yes.
Always.
Yes, ma'am.
Always, whenever the water will touch us, so that is a stimulus to us. We don't know what was that reason, but it is a behavioral pattern which is there in our life since the childhood. And the behavior, that nerves are more stimulated in some cases. Okay, in some case, when the nerve pathology is also there, or that might trigger your detrusor to get active. Or sometimes the smooth muscle is a behavior. We don't know why it is triggering, what is causing it to trigger. But whenever the overactive hyperactivity of detrusor, if this is written into the referral form, and if it is written the patient is having urge incontinence, one thing in come into the brain is nerves are involved, which is situating. Second is, then we have to differentiate, is it only the nerve or pelvic floor is also weak? So then we have to ask another question to our patient, that like she will tell you that I have a strong urge, and then I have to go to the washroom and urinate it. Okay, so are you leaking on the way of washroom? No, I'm not leaking on the way of washroom. If she's not leaking on the way of washroom, are you maintaining that till the time you are lowering your pant and you're sitting on the commode, you were able to hold? Yes, I was able to. There was no leakage, but there was a strong urge. So leakage was not there. It means the pelvic muscles are strong. So there was no leakage, but she was having strong urge. So we will call it as an urge incontinence only because of the nerve involvement. Second is the question, if the answer of the question is, I have strong urge and I cannot hold, even I leak on the way of my washroom. If the patient leak on the way of washroom, it means the pelvic floor muscles are also weak. So then we have to do nerve stimulation, as well as we also have to give them the muscular training, pelvic floor muscle rehabilitation also. We have to strengthen the pelvic floor as well. Clear about this? In which case you don't have to strengthen the pelvic floor, only the nerve stimulation. And in which case you have to do the both.
Yes, please.
All right. So this is the urge incontinence. And your patient will tell you the symptoms will be sudden involuntary loss of urine because of detrusor overactivity, causing strong urge to void, and patient will tell you sudden urge was there. Why the sudden urge? Uterus, this detrusor started contracting and moved the urine leak downwards, and internal sphincter open up automatically, and all the load fall over the pelvic floor. Urine loss on the way of washing. It means the detrusor nerves as well as the pelvic floor is involved. Urination can happen without any warning, anytime, any position. So unpredictable behavior can be there, means nerves. Now, what is the difference between stress incontinence and urge incontinence? Once it is a stress, that is a predictable behavior. I know that I'm going to jump. I know that I'm going to push, lift. I'm going to sneeze. I'm going to cough. So before even sneeze and cough, 4 and 5 seconds of time is always there when we can we can know that I'm going to cough. But in this case, urge incontinence, there will be no signal at all. Prior predictable behavior will not be there actually. So this can happen anytime, anywhere. This overactivity of bladder can happen in night too. So not when this suddenly we are going for sleep, and like suddenly you found that, oh, there's a sense urinary urge is there to urinate. So you are getting up at the night, and if you can get up and kind of control and good sensation is there, in middle of the night, 2, 3 times, 4 times, you have to get up. But you are not leaking on the bed, but the sensation is high and you are feeling that, no, I have to go and urinate. And you are getting up and it is disturbing your sleep, and you'll get up, you'll urinate, again, you'll come sleep. Again, it will be sensation, you'll go and again. So night time, you are going 2 or 3 times. So this is what we are saying, a nocturnal behavior of your urine. But another thing is nocturnal enuresis, or sometimes can be leakage. Might be pelvic floor muscles are not strong. Your levator ani is weak, which has to maintain the nighttime tone. When you are resting for a long time, your pelvic floor muscle levator ani will always create an extra tone, develop extra tone. This is the behavior of a levator ani. Endurance, they will maintain the endurance during the night time. But if the pelvic floor muscles are strong, you will not do bedwetting. But if the pelvic floor muscles are weak, levator ani is not strong enough, you might even go for leakage also. You might have seen that many of our kids at the pediatric population around between, like, what is not normal is from 6 to 12 years. Before 6 years, if the leakage is there, so we can still understand that her system is still getting strong. Still the bladder training is going on in the kids. Initially it was 4, but now it is 6 because we are giving them diapers. That using a lot of diaper, our kids. So from the time between 6 years to 12 and 14 years, this kind of behavior is there. They're still leaking on the bed. So this is what we are saying it during the night time. So we are calling it as a nocturnal enuresis, leakage during the sleep. So they are into the deep sleep, and the nerves was not able to send the right signal to the brain, and they were not getting to know it that they have to get up and urinate, or might be the nerves are triggering them detrusor to contract at the night time. So whenever there's leakage is going on, bedwetting is going on, we'll call them as a pelvic floor weakness as well as nerve weakness. But if there is no leakage, but they have to get up again and again, still it is a nocturnal enuresis, but the pelvic floor involvement is not there. Anything, as I told you, sound of running water, lock and key syndrome. Lock and key syndrome into the pelvic floor muscle means whenever you are opening up the lock of your house. So this pattern is a stimulus to your brain that you are trying to open up the door and you are not able to it. You are not able to maintain it and do it. Or you might just park your car. As soon as you park your car and you will see the door of your house, might be nervous system will get triggered. Okay. So this is a urge incontinence. Third is
I would like to share one thing. Like with my son, I would just like to share a case. So just so everyone can relate to it. So my son, last year, he had this problem. So he was having leakage over and over and over and over again for 3 months. I suffered a lot. I was changing his.
How old, Dr. Smriti?
So right now he's 9 years old, going to be 10 in October, but he was 7 years, I think, last to last year it happened. And it was happening during the day only. So going to school was very difficult, and it was very stressful for the child because other kids are there and he is getting incontinent and all that. You can understand, they have a very immature mind at that stage. You won't believe, I took him to the pediatric pelvic therapist, and I didn't have that much knowledge that why, because in the night he was not having any trouble, only during the day he was having trouble. So when I took him to the pediatric pelvic physio, she started doing that biofeedback thing, that she connected some electrodes on his private part, and she asked her to squeeze and then look into the, that visual thing, you have to squeeze it. But then my mind was not accepting it, because it's not happening at night, so which means it's not something related to his behavior, something at the physiological was happening. So actually it was an overactive bladder, it was irritable bladder syndrome at that time. So we got there was no issue with his pelvic floor. That lady was giving him pelvic floor muscle contractions. So she should have understood that if it's not happening at night, it might not be because of the pelvic floor weakness, but it was something related to his nerves. So I don't know, so then we got a homeopathic medication, and within 2 days he got better, and third day he was not leaking at all. So we continued that medication for almost 2 months, I guess. 1.5 to 2 months we continued, but I suffered a lot because of this thing,
So,
because I'm not aware that what's going on.
yes, so now you can understand that homeopathy medicine was helping him to resolve the problem related to the nerves.
Yeah, so it helped with the nerves actually. So if it is something related to the nerves, it's not related to the muscles. For example, if the lady is saying that I have a strong urge, but I can still hold. So
Yes.
then we do anything about it other than the habitual thing?
Yes, we have to give them that nerve stimulation, the nerves which is supplying the bladder. So sacral
Oh,
stimulation and the posterior tibial nerve stimulation. These are the two nerves which is gonna supply the detrusor muscle. So you have to stimulate those nerves.
okay.
Okay. So nerve stimulation is the solution in that cases. And believe me, within 5 to 7 session or 12 session maximum, 90% your patient will be recovered. You're not spending a lot of time. You're just giving them the nerve stimulation like this. Let me show you.
Wow. My son suffered a lot, a
You
lot.
could have known that you might have given him this, only this one simple thing, and he might have been
I
okay.
have all those equipments, but then I never knew all that.
Let me show you.
That gives me a lot of anxiety. I cannot deal with the pediatric population because it takes me back to that stage where,
And you don't even have to do the stimulation on the private part. The stimulation should be over the posterior tibial nerve. This is
so
the
she was actually giving some on the adductors and some on the above the pubic symphysis, something like that. So it was, now I feel that,
it was a pudendal nerve stimulation, which was not pudendal nerve stimulation is for the pelvic floor.
yeah.
So what we need here is a tibial nerve stimulation, posterior tibial nerve stimulation, or the sacral stimulation. So this is the stimulation which we have to give to these patients who are suffering from PTNS, posterior tibial nerve stimulation, who are suffering from urge incontinence. I'm so sorry. Urge and overactive bladder. Believe me, the new studies which is started publishing from 2019, and many studies are there, evidences are there, that only not only once per month, per week, it's like 3 per week, 3 sessions in 1 week, and 30 minutes of session if you'll give to your patient within 12 weeks, your patient will be fine. Or within, even you can say that 12 sessions also. I've seen my patient in recovering 10 to 12 sessions, 100% recovery is there. So patient will come to you, you will just apply this stimulations, and then it's good to go. Nothing else you have to do.
So just above the medial malleolus, one electrode is there, and one is the another one anywhere, you know.
Anywhere, it is anywhere you can apply. And the same electrodes, you can even do the stimulation with the needle. You can stimulate the needle also. That will be more effective even. That will be a form of invasive. So this is non-invasive, and that will be invasive, the stimulation of to the nerve with the needle. And we have to give the stimulation to both the legs, the right and the left. Both legs needs to stimulate. The needle stimulation. So these kind of even probes.
Dr. Sunita, how does this actually work? I'm not understanding this. The tibial nerve stimulation.
I'll give you understanding, but just when we'll understand, we'll go in more detail. Then you will be able to understand this. Okay. So these kind of tools are even available, not available in India. Special design PTNS stimulators are there, which is there in Canada, Australia. They are not. If you'll come to India, please buy one for me. Also, it's not even available in US. I tried to find out. It is in Canada and Australia. Australia is the company which is creating, manufacturing these PTNS stimulators. Okay, so
it's not a regular TENS machine. It's a separate.
It's regular TENS also you can use.
But then
You have to
you're
set that the frequencies. We will discuss about that when we'll discuss the rehabilitation part. Is it okay?
Sure.
All right, lovely. The third type of incontinence is overflow incontinence. Urine leakage is due to over-distended bladder because of now why the uterus is why this bladder is keep getting full of the urine. So means urine is coming from the urethra and the whole bladder is, can you see in this image, keep extend, the filling is going on. And it will keep putting pressure over your detrusor, and detrusor muscle will be more relaxed detrusor, more open detrusor. This is one situation. Urine, we will feel, if you palpate the bladder over the suprapubically, and the pressure will be there, tenderness we will feel. As soon as we touch, the patient will say, ma'am, I have this feeling, it's full. And we can also feel that kind of tenderness over suprapubically. Too much of upper abdominal movement of the bladder will be, palpable bladder will be. And why the urine is getting trapped into the whole bladder? Because it is going to keep sending the signal to the brain that go for urination, I'm full. Female will go for urination, male or female or kids, they will go for the urination and they will sit down into the washroom and they will try to pass the urine, but urine will not come outside. Pressure will be so much high, it will keep triggering her brain that I have to pass, but the minute they will go to the washroom, they will fail to pass the urine. And they might start putting a lot of voiding force. They will pressure, they will apply the pressure to release that urine, but still urine will not come. It means something is affecting the passage. Some obstruction is there into the passage. So this bladder, okay. So this is a urethra. So urine is keep filling, keep expanding the bladder, but it will not go into the urethra. It means some obstruction is there into the urethra, some kind of obstruction because of any reason. Urine leakage due to over-distended bladder because of any obstruction of the urethra. Might be the obstruction is kind of involving covering the half of this kind of passage. Some passage is there, and from this some passage, some urine drops will keep coming outside. So leakage kind of feeling can be there, okay? But the complete emptying will not be there. Pressure will be always maintained. This is because of, it can be because of cystocele when your bladder is falling backward. It can be because of your urethral strictures, something happened with the urethra. It can be because of some obstruction inside the internal orifice here, something is obstructed, or it might be some obstruction into the urethra outside here, or might be some inflammation around that vestibular area. Your vestibular area is inflamed, and that is not letting you to pass the urine. But inflammation is there, it means the burning and pain will be there also. If burning and pain is not there, pain and burning is there, means inflammation. So doctor will give her anti-inflammatory medicines. But if pain and burning is not there, so still that issue is there, overflow is going on. So now in this case means some obstruction is which is not letting the bladder to relax, and it is squeezing, something is squeezing the bladder from somewhere. So what can be the squeeze? Okay. Now squeeze can be, let's see what can happen here. Might be the tightness of the ligament which was holding the urethra. So some kind of issue, some kind of trigger, or some kind of tightness happens into pubo-urethralis ligament. Tight. If it will become tight, it will keep pulling it anteriorly, urethra. So urethra will be kinked anteriorly because of the tightness of this bladder. Might be some injury happened which created those kind of effect, tension into the pubo-urethralis ligament. It can be, what else it can be? It can be prolapse, like your organ is falling backward. So it means the prolapse can be because of two things: the overlax ligaments, which is holding that, or might be lack of support from the posterior side. Vagina is not supporting, or weakness of the pelvic floor muscles. Anything can be the reason. So uterus will start falling backward. So uterus should be like this, bladder should be like this, but bladder will start falling like this. So if bladder will be like this, let me form it for you. Let me make it and make you understand. Share. Okay. So normally, this is the bladder. And this is our vagina. Normal behavior. Okay. Now what happens into cystocele? So now what can happen here? The ligament which was supporting here, urethra, is tight. It is keep pulling it towards the pubic symphysis. And because of the tightness, the kink is formed like this. It is moved like this, closing. And that's why the leakages keep going on. And it is creating a distension, keep filling the urine into the bladder, and over distended bladder. Overflow is going on inside the bladder. Too much of urine is stored. That can be one reason. Second can be the bladder is start falling backward. Like this. So it started falling into the vaginal canal. Because vagina is weak, it cannot maintain that tone. And into this, this posterior part is sagging down, that will be filled up with the urine. And she will keep all the urine, whatever is present here, as per the gravity, that will come outside. So means the problem is not with the urethra, problem is with the positioning of the bladder. Posterior wall is falling downward into the vagina. Cystocele, prolapse of the bladder. And into this particular part, there will be kinking of the bladder, and into this kinking, the liquid will keep filling, and that is going to give her a kind of a feeling of pressure inside, and she has to, because this pressure will, we have the trigone will be stretched out posteriorly, but this upper part where we have this interstitial wall, this mucosal wall, that will be distended because of this pressure going over the stretch receptors. So that can be keep giving a signal to the brain that I have to go, but female will go. All the urine which is here, that will go outside, but the urine which is into the posterior part, into this kink, it will hard for her to, because it can't come out as per the this positioning, faulty positioning it is acquired. So that can be one reason why she's having that. In this case, palpable uterus will not be there. Palpable bladder will not be there. Will palpate, there will be no, you can't feel the bladder. But you can feel the bladder inside the vagina. If you insert your finger inside the vagina and you'll do the pelvic floor examination, and your finger will feel some pressure is falling. And as soon as you press the bladder from your finger by applying this anterior pressure, so now the bladder is falling like this, and I'll insert my finger and push it anterior. As soon as I'll push, the urine will come outside. So on our examination, transvaginal examination itself, we'll push it anteriorly, from by putting pressure over the anterior wall, we'll push anteriorly and urine will come outside. So it means she was having this pressure feeling because of the cystocyst. So that can be one reason why it was distended and the overflow was going on. There can be, and that same thing can give a patient coital incontinence. She might tell you that I'm having leakage during sexual intercourse. Why? Because whenever during sexual intercourse, penis is going on, penis will push it anteriorly, and because of this push, the urine will come outside. And she will feel this, oh, urine came out. And because of this embarrassing situation, she might stop engaging into sexual activities also. She felt it, and she might don't tell even to the husband, but once the leakage is there during that pleasurable activity, so she will not feel orgasm. Her brain will be engaged in, oh, I wet myself, it's urine came out. And the smell will also be there into that case. Might be the partner will find out, or partner will not be find out, but she will not be engaged into the same behavior next time. She will try to avoid sexual activities. So this is not only going to affect her, even she's going to affect her relationships as well. We call this as a coital incontinence. Incontinence during the coitus activities. And same can happen with male prolapse.
Considering that the vaginal support isn't there, so does it happen more frequently with male?
No, because male are having good, strong support from the prostate gland. Prostate gland is maintaining the support. But till the time prostate gland will be removed, for example, because of any reason, they remove the prostate. So support will not be there. So then the pressure will fall over the ligaments, and that can give this fall. So fall can happen into the rectum, rectal prolapse. The bladder will come into the rectum by putting pressure downwards. So this person, during the constipation, if she's during the passing of stool, whenever we are passing the stool, our behavior is different. When you are engaged, you are urinating, you are not passing stool. When you are passing stool, you are defecating, you are not urinating. When you are involved in sexual activities, you are not urinating and defecating. One time, one sphincter, either the pubo-urethralis will create a kink, either the pubo-rectalis will take a kink, or either the pubo-vaginalis. They all will not create a kink all of a sudden, closing or releasing. That will only happen when we voluntarily doing it. We are training ourselves. If I tell you squeeze your pelvic floor, so all the muscles will be squeezed. You are doing it voluntarily. If I tell you, okay, release your pelvic floor, relax the pelvic floor, so you are relaxing them voluntarily. But normally, during the functional activities, urination and defecation never comes on the same time. So you even check with yourself next time when you go for urination, or you will go for defecation specifically. So when you're passing the stool, you're not urinating. As soon as you stop passing the stool, then urination will come. Or might be first you will urinate and then the defecation will come. So one muscle is pulling one time. This pubococcygeal segments, either the pubo-urethralis is creating pull, or the pubo-rectalis is creating a pull. Okay, so now in this, sometimes if the patient is having, male patient specifically, and even female also, we also as a female. So if we found that we are defecating and we are doing defecation, voiding force will be, this voiding pressure will be always, abdominal are going to create a contraction that will help in voiding abdominal, the contractions activity, voiding force will be given by the abdominal muscles. They will press abdominal content, they will squeeze that pressure which is going on into the large colons. They will be pushed and moved posteriorly, and that they will help into moving this, squeezing the colons, the abdominals, squeezing the colon. So whatever there into the large colon, that will come into the rectum. And now from the rectum, already as per the gravity, we have a relaxed pelvic floor because we acquired that position. Whatever stool is coming into the rectum, because the angle is also released, the puborectus muscle is relaxed, external and sphincters are relaxed. So whatever stool will be into the rectum, that will come downwards. So that contraction and even the relaxation of the pelvic floor is also going on. This is the right defecation. But in some cases, what will happen actually, if the prolapse is going on posteriorly, in the male patient, the bladder is collapsing into the anterior wall of the rectum. So as soon as the stool will move, it might move that bladder anterior, because stool also needs space, and contraction is also going on from the abdominal. So the male, or that you can feel that behavior, we can ask them, we have to ask them this symptom. So during defecation, they will also feel the urine is also coming outside. So urination, why urination happens here? Because of the push from the back of the stool. So urination and defecation, both. Something pushed from the rectum, the stool pushed from the rectum. Or might be patient is putting lot of voiding force, and that voiding force is also generating pressure down there. And when the voiding force is there, we are not only squeezing that abdominal content and pressurizing the colons to empty, we are also, the squeeze is like pelvic floor and the abdominals are antagonist. So when that is contracting, pelvic floor will relax. When this is contracting, that will relax. Both will not contract together. So they are always working against to each other, abdominals and the pelvic floor. So if you are doing the voiding pressure, so we should, that's why we are saying, we are always giving this tip to our patient: don't apply voiding force. Once you apply extra voiding force, let your body generate it. Don't extra add it. Once they will start, that is gonna put extra stress on your pelvic floor muscles. So in this case, not your rectal muscles are relaxed. Even the voiding pressure is making your anterior urogenital muscles too strained, and because of the strain, might be you are creating the weakness. So this is what we are calling it as a mixed pelvic floor dysfunction. Patient has to put voiding pressure at the back to defecate, because the muscles might be not relaxed completely, or might be stool is very hard. So it is putting pressure to open up the passage and bring that stool out. But that voiding pressure is putting pressure unnecessarily over the anterior compartment. So some obstruction is posteriorly, which patient wants to defecate, they want to evacuate, but anteriorly laxity, weakness is they are generating, like habit. Many patients, they might have this kind of habitual pattern, and because of the habitual pattern, they will end up into weaker muscles around urogenital triangle and or constipated stool at the anorectal triangle. So stool never should never be that hard stool, tight stool, those particles. It should be a fibrous diet, liquid, so like kind of some consistency of stool should be always there, which should not put unnecessary strain on you don't have to apply the voiding force. Okay. And even gas should not be, digestive issue should not be, gas-like sensation. They might have this gas going on into the intestines, and they're putting this voiding pressure. There's no stool, the gas is just all moving it. So that's why this very, very important is the digestive, maintaining the good digestion and food habits. And second is good positioning, acquiring the right positioning, and don't put voiding pressure. Otherwise, you will end up into weak weak urogenital triangle. So this can be the reason of leakage when they are defecating. Urination is coming, as that can in case of male. And male who are involved in anal sex, or that can be anal sex with male to male when they are having sex. So then that might give them the coital incontinence also. So this is the third, overflow. It can happen because of cystocele, urethral stricture, urethral stricture. Urethral is kind of tight somewhere, pulled by something. sign and symptoms can be continuously, periodically. Okay, these urethral sphincters overflow can be because of the tight pelvic floor. I'm sorry, I forgot that. If the muscles around the urethra is external, this pelvic floor muscles, they are tight around the urethra. It can be because of any issue. Okay, tightness is there. Whole compressors are tight. They will keep pulling. They will not relieve the pressure. So that tight pelvic floor can be an issue of that overflow. And in that tight pelvic floor, there will be always suprapubically tenderness. Feeling of bladder fullness will be there. And in case of cystocele, there will be there will be also feeling, there will be no suprapubic tenderness, but the feeling of bladder fullness will be there, which will motivate the patient to go again and again to use urinations of urinary frequency will be also high. And the third is, patient will always complain you that I'm having some pressure inside my vagina, or I'm always having some pressure inside my rectum. Male will tell you that pressure is there into the rectum. Pressure will be there because of the liquid, the prolapsed bladder. Okay, so feeling of pressure into the canals. The canal can be vagina, or the canal can be bladder. Sorry, this anal canal. Oh, sorry, rectal area. Patient will also give you this thing that they have to put strain to void, and whenever they are straining, they are creating extra weakness on the pelvic floor. So that is, they are somewhere creating a problem. Again and again, they will apply strain. So means overuse of the pelvic floor is going on. So that will be a cause of weakness of pelvic floor. And they will try to put strain, but the stream, urinal stream will not be the strong stream. It will be weak stream, or might be drops will come. So stream will not be strong. So weak urinal stream will be there. And after urination, as soon as they will, okay, now they will start spending a lot of time into the washroom, 5 minutes, 10 minutes, 15 minutes. Again, they will get up because they will wait, because the pressure is there, feeling is there. They will try to empty, but still they are waiting since 5 minutes, 10 minutes. They might get up. As soon as they will get up, as soon as they will come outside, again, the feeling will be there, oh, I have to go. And again, they will be going, because feeling of incomplete voiding will be there, because complete voiding is not happening. And not only this, after, if the obstructive urethra is there, some kind of mild obstruction is there, might be some stone part, like stone came from this kidney stones are there. So those kidney stones can obstruct this urethral upper side. So this was the canal, and the stone is now, this much of big stone is present here into the internal canal, internal opening around the internal orifice. And that is creating an obstruction. The stone is creating an obstruction. And we have a mild passage. So urine will keep coming out from this mild passage. Patient will also apply the strain, and even dribbling can continue when obstructed urethra will be there. Half of the urethra is obstructed. So that can be a reason. The stone, kidney stone, can be a reason of this. It can be that some tension from half of the tension going on, half of the urethra is outside, anteriorly pulled. There is still obstructed urethra. From some of the urethra, urines keep coming outside. So dribbling can be also there. Might be another thing which can happen here is stone infection. Yes. Inflamed urethra, urethral internal structure is inflamed, and because of that, but in case of inflammation, there will be always burning sensation. So yeah, so that can be even reason of post void dribbling. So that will be one common symptom they will tell you. Another is feeling of going for urination again and again, but not able to urinate. Always have the feeling of incomplete voiding. Post void dribbling, weak urinal stream. Okay, now we can understood that patient is having overflow. So how we can help in overflow? If the muscles are tight, pelvic floor muscles are tight, and this is the reason of overflow, so we can relax the pelvic floor muscles. But if pelvic floor muscles are not culprit, the culprit is something else, then the diagnostic procedure is very important. Patient has to go for all the reports and find out what is creating this kink. If the prolapse is that reason of this kink, So we can even take a help from the pessaries are there. We can insert the pessary. We can support that positioning of this bladder by inserting the pessary inside the vagina. So in case of cystocele, we can help. In case of when the pelvic floor muscles are tight, we can help. And if the ligament which is tight, which is holding puboiatrice ligament is tight, we can also release the ligament from the transvaginal approach. But if other cases are there that obstruction is because of some stone or some internal factors are involved, so we cannot do anything in this case. So taking a detailed history and going through the reports, why the overflow is there. The reasoning is very, very important. And that will help us to decide that can we help in this case or we cannot help in this case. If you cannot help in this case, still we will try to initiate that relaxation. So we'll ask our patient to just relax the body, because this accept this situation and treat the situation from the right person. And the relaxation is very, very important. And don't put strain. So right guidelines is very important. Education, giving them the complete education is important. So that is the overflow. Number 4 is a neurogenic incontinence. I don't found neurogenic incontinence is something different. Neurogenic incontinence means some nerve involvement. So that nerve involvement comes under the overactive bladder also. And nerve involvement can be the reason of pelvic floor weakness also. If your the pudendal nerve is not sending the signal from, they're not asking your urethral compressors to contract and release. So that signal is not there. So nerves which is supporting the pelvic floor, or the nerves which is supporting the bladder or urethra, they are having some issues. So according to that, we have to give either, depending upon what is the problem, we will give them the sacral stimulation or posterior tibial nerve stimulation, or the posterior the pudendal nerve stimulation. Okay, nerve stimulation is very important in case of neurogenic incontinence. 5th can be mixed of any of these. It can be the stress and urge, it can be the stress and overflow, it can be the urge and overflow, it can be that neurogenic and overflow. So any two are merging with each other. So that is a mixed incontinence. 2 types of incontinence are there. So these are the different types of incontinence which is present. And in male, we should always keep in our mind that bladder emptying, during the emptying and this bladder behavior, the prostate gland has a big role. Prostate gland is always, it's like a grasping around the urethra. It will always keep some kind of pressure, and it will give a support to this lower part of the bladder. So once the prostate will be removed, if the prostate is swollen up, some kind of infection is going on, inflammation is going on into the prostate. So that because of inflammation, that can put pressure over that urethra, and urethra will be compressed and squeezed, and that can be the reason of overflow incontinence. Or they might keep putting stress, strain, but urine will not come out because of this swelling, that compression, because of that prostate gland. So in those cases, infection, they have to release this inflammation, and as soon as the inflammation will be released, then the flow will be good. But in this case, inflammation means might be inflammation will not give them the signal that always there will be painful urination. Okay, that will be the one symptom of your patient. In male,
ma'am, even in BPH cases, we find this problem. Benign prostate hepatomegaly.
yes.
Dr. Sunita,
Yeah.
so what in case one of the sphincters are damaged?
Yeah. That is an internal tissue damage. One of the sphincter means the sphincter, no?
Yes. So then there is a complete incontinence?
Yes. No, not a complete incontinence. Depending upon internal sphincters are damaged, so how strong your pelvic floor muscle is. If pelvic floor are strong, so you might have the coming pressure, or you will have that kind of urge that no, the pressure is there and you have to urinate. So in this case, again, depending upon how strong your pelvic floor. If both the sphincters are weak, internal also weak, and internal sphincter damage means urethra will be relaxed urethra. Urine will always be into the urethra. But still, how strong is your pelvic floor? Pelvic floor is the main important muscle. Okay. So there will be no continuous leakage. But yeah, if the pelvic floor is weak, in case there's no sensation around the pelvic floor, internal sphincter sensation is not there, pelvic floor sensation is not there in case of stroke or this kind of spinal cord injuries. So then there will be continuous leakage.
So there was this one case where the sphincter in the internal sphincter was damaged secondary to some surgery, and the patient we had advised for Kegels. The patient did it for about a month, but then he said there's absolutely no difference.
It's fine. No difference?
No difference.
Okay.
He says, I still have no control, and he's still totally
So
diaper dependent.
have you already given him nerve stimulation also with that?
No.
So we have
So
to,
the thing is now
now we can
they
understand.
ref
It's like everything we have to focus on: nerve stimulation, muscle strength, pudendal nerve stimulation, sacral nerve stimulation, as well as like pelvic floor muscle. Like he's doing Kegel, but we don't know that he's doing Kegel right or wrong. Yeah. Right Kegel is doing or not, right contractions doing or not. Or in this case, when we are talking about that this sphincters, external sphincters around the urethra. So I told you that best is that the transvaginal and transrectal electrodes, because this is the middle muscle which we have to create strength into. So stimulate the middle muscle, pelvic floor muscles. So we need probes which you can insert into those orifices, and those probes will stimulate them from this metallic plates. We have to insert that inside the rectum or inside the vagina. Biofeedback devices.
So, and this patient is about 80 years old. So, we also stopped pushing much after a month. We
But
again put it across.
we should always try by taking the help from biofeedback devices, transrectal stimulators, using a lot of transrectal stimulation and transrectal like muscle, just checking the strength of the muscle on your finger, how strong they are, how weak they are. So it's the complete protocol, and we are only Kegel is what is Kegel? Kegel is just a contraction, and we don't know the patient is doing it in the right way or not. Is not doing in the right way. So
with women, like even if we're doing the digital method
finger.
of so we usually insert in the vaginal to see if the am I right? I'm not sure.
Yes.
So for men, it is usually rectal, is it?
Rectal, yes, rectal, because what's behind the how we can palpate, from where we can palpate, from rectum only we can palpate their prostate gland, and we can palpate their bladder from the rectum.
So even if we have to check if they're doing their Kegels properly, it has to be the rectal only.
Rectum.
Okay, and do you think this population of 80 years and above
Like
will
it is very hard because aging also has a factor, hormones level and the sagging of the body, atrophy going on, everything. But still, nerves you can try to give them the best from your side, whatever you can achieve. So we cannot achieve 100%, but still we can achieve 40%, 50%, and some release can be there. In those cases we have to focus more into bladder diary, bladder retraining. So this is another part of rehabilitation, which depending upon, like we will give them the timetable, like we are giving them will not let their bladder to get filled up, so the leakage can be more. So we'll give them the timetable that you have to go for urination 10 o'clock, 11 o'clock, 12 o'clock, 1 o'clock, 2 o'clock. So timetable will make for this kind of.
But Dr. Sunita, when the internal sphincter is affected, will this help? Because there is nothing retaining in the bladder at all, right?
Look, internal sphincter is creating a pressure, upward pressure inside. It will not let these particular things to go out. But the thing will go out if the external door is also there. There are two doors. If one is open, but other door still has some kind of strength, endurance or strength and power, So whenever the sensation will be there, the patient might make their room to go to the washroom. They might hold for 10 seconds and they can go to the washroom and then urinate.
No, this patient was like totally no. He was like, I do not know when it is filling and I don't know when it is
Yes, it's a
voiding. I
nerve.
am
It was too much of nerve involvement in his case. So we required nerve stimulation in those cases when the feeling is not there. And we need to take a help from those kind of modalities also, not only the nerve stimulation, even the re-education, the muscle action, they don't know. So we have to re-educate the muscle action by applying some kind of vibrators over the penile body, so they can feel this vibration and squeezing effect of the pelvic floor. So more of the depth training is there for those kind of patient. Yes,
okay. Yeah,
you
thank
will
you.
understand. You will understand that in upcoming slides. So I hope all of you are aware about now the pathology, urine incontinence. You understood completely now.
Yes, please.
So next problem. So that was the problem related to your bladder. Anything else is coming in your mind which you think that related to the bladder and we have to focus on? I think, yeah, this is the only one. Either the bladder, smooth muscle, either the nerves, either the pelvic floor, or might be the repositioning, or might be the ligaments, which is tight or over.
Ma'am,
Yes, Dr. Rashida?
Dr. Sunita, this is Rashida with you. I have a question. I deal with spine patients. Most probably all are post-surgical cases where some of them present to us with spinal cord injury or some discitis due to which they are paraplegic or paraparesis. So in that there is issues with the bowel and bladder senses, right? So in that case, we can help them with
Yes, stimulations. You know,
stimulation.
we are doing Faradic stimulation, but once
Even
the muscle,
even if there is complete cord
yes,
lesion, even though it will help.
but not the Faradic, galvanic.
Galvanic. Okay. And in cases of spondylodiscitis, where tuberculosis or cancer is involved, still we can use these techniques, right?
Yes, we can use it.
Okay. Thank you. Thank you very much.
And even sensory stimulation also, not only this galvanic, even other form of the sensation. We will try to find out which area they have a sensation, up to which area. And if the sensations are not there, we'll try to give them the galvanic stimulation to make these nerves to get active. And the second is even keep applying the hot water, icy water, ice application over the glutes, over the sacrum, ice over the perineal body, ice therapy over the perineum, ice over the penile body, because penile body is more, because either they are still having this kind of issues with their nerves, they cannot control their bowel and bladder, but always they always have this sexual stimulations. The sexual stimulation is the one thing which will come first. So it means sex organs are controlled not only by your body, even if they controlled by your brain, your mind. If those kind of thinking will come in a mind, those sexual sensations and thinking, that might trigger, that is a kind of stimulation for your area, for your nerves. So in those cases, applying this ice packs over the penis, over the what we are saying here is the glands of the penis, and vibrator, using lot of vibrator over the penile body or penile glands, perineal body, they are going to be a great help. I found it a great help in my practice. You can activate, you can stimulate. Once you will just out of 100%, if 1%, 5%, 10%, slowly will we have to try to activate those sensations down there. The use of all the sensory stimulants or this galvanic stimulations, hot and cold touch or vibrator touch, or those kind of feelings. You might have to engage the partner and tell them that, try to show him your genitals and try to make him to involve in this sexual activity. So internal brain will get active according to what age of the patient is, and as per that. So partner involvement is also important. Start touching the sexual organ again and again, and start your doing, partner will stimulate herself in front of the male. So that is going to trigger the brain to react. Okay. So this is the bladder, which we discussed. Another problem, now let's come to the posterior side, other issues. Yes, so I sent you the video yesterday about endometriosis, if you have gone through that. So endometriosis can also affect our whole visual pathologies and in the pelvic floor. Interstitial cystitis, you now understood. Vulvodynia is one condition where we don't know why. There can be many reasons, but there will be always some kind of persistent, unexplained pain over the vulva. They might don't find out where the pain is there, but the vulva is painful. What is vulva? Vulva is made up with your mons pubis, labia majora, labia minora, your penile body. They all are the part of the vulva. So pain can be around the clitoris, pain can be around the round ligament, pain can be into that. We don't know where the pain is. Whole structures around this area, anything. It can be the nerves, it can be the pelvic floor muscles, bulbocavernosus, ischiocavernosus. It might be that the clitoris. It might be the suspensory ligament, which is holding the clitoris. It might be the round ligament, which is holding the uterus. It might be your labia majora inflamed. It might be inflamed glands that the bulb of vestibule is inflamed. Might be the Bartholin gland is having some kind of problem. Might be this, or there can be some obstruction into the passage of those glands, paraurethral gland or this Bartholin gland. So those opening. So something is going on. I don't know what is going on. Or it can be the nerves, which is good, this pudendal nerve, which is supplying that area. So anything. So we, on a broader spectrum, this is what we can say. Patient can tell you, okay, I don't know where the pain is. So generalized vulvodynia, they are having pain into the vulva. They cannot localize the pain. And sometimes patient can tell you exactly here I'm having pain. So when it is exactly here, so it is easy for us. But once we don't know where the pain is, so in that case, our main thing is vulvodynia, pain is there. So first thing as a physios, we will try to do something which will subside the pain. So the icing is the first, ice application is very, very helpful. And the second is, because inflammation might be there, whatever the cause, ice will be the first line of treatment in this case. And second will be the TENS. You can take a help from the TENS also in case of vulvodynia. So what is causing the pain? Cause can be inflammation of those structure, hormonal factors can come, some kind of genetic issues are there, injury to the nerves which is supplying that area. It can be some kind of infections which is going on, might be the weaker pelvic floor muscles, weak, like kind of spasm into the pelvic floor muscles. Pelvic floor muscles are hypertonous pelvic floor. Bulbo is hypertone, and the connection of bulbo and ischio is there on the top, which can give them the even sexual pain also, or pain around the clitoris, or deeper pain, which they can feel inside the vagina also. So that can be a cause because of the pelvic floor muscle weakness, pelvic floor muscle spasm, not a weak pelvic floor, it's like a pelvic floor muscle spasm. And it can be because of the irritation from any kind of products they are using over that area. So that is a more chemicals, might be some kind of spray they are using, some kind of that can create an irritation of with the structure, skin and tissue, and that they might get this kind of inflammation. So vulvodynia, patient will tell you, she can tell you that he or she, that burning sensations are there, stinging, stabbing, itching, rawness, thrombing, or just a pain. I don't know where it is. The pain is there. So diagnosis, how we can do is we have to palpate the area with our finger. We'll try to localize. We'll try to tell them, okay, can you show me where your pain is there? And if they cannot palpate, we'll try to tell them, okay, try to put pressure over each area. And still they cannot tell us, then we will do the physical inspection, that where is the inflammation? Is there any sign of redness, inflammation, or what can be that can be the source of, or we'll do that palpation with our fingers. We'll palpate the pubic symphysis, labia majora, we'll hold the tissue, we'll touch the tissue, we'll put a deeper pressure over the tissues, we'll try to localize and try to find out the whole clock where she's having pain, exactly which areas. And physical inspection with your, like the visual only, you can just look at the structures, or you might be palpating the structure with your hand, or very, very soft structures like the this vestibular area, the urethral area, vaginal area, where we cannot touch directly with our finger. We might take a help from the cotton swab test. So take this earbud is there. So you will use a earbud or the cotton, and we'll dip the cotton in a gel, the physio gel or the oil, and very slowly we'll try to apply that cotton swab around the sensitive area of a female and try to ask where exactly the pain is there. Even into the by palpating, doing this palpation into the sensitive vestibular area also. So cotton swab test can be there. Point pressure testing is also a method. We'll keep putting pressure over all these structures, and we'll ask our patient where exactly the pain is there. Or at the final, if we don't found anything, we will send them to doctors. We will refer them for the testing for infections. Okay, if we don't know why this where exactly. So might be the internal vestibular gland is in fact inflamed and infected, might be some kind of infections going on around the cervix or around the urethra, so which we cannot see outside, and because of internal pathology, they might have those kind of issues. So all these things can create a vulvodynia. So this is again a condition. Fourth, so this is the tension. It can be because of tense structures. Next can be vaginismus. Vaginismus is like a complete blockage of the superficial muscles of the pelvic floor. Bulbocavernosis, superficial transverse perineum, ischiocavernosis. There's a spasm into those muscles. As soon as you will go close to the vagina, the muscle will go for spasm. So otherwise, once you are not going closer to the vagina, it is okay. But as soon as you go closer, the spasm can come into picture. So vaginismus can be because of the spasm, or vaginismus can be the muscle can have a spasm also, or muscles can have a tension also, tightness also. So that tension can be because of some physical activity, like sensitive nerve around the opening of the vagina. Sensitivity, you are very, very sensitive, oversensitive. Someone is coming near to you, your muscles are going for this guarding reflex, closing reflex. More sensations are there, which is creating the closing effect around the vagina. That can be the reason of vaginismus. You cannot go inside the vagina, you cannot penetrate inside the vagina. There can be inflammation is going on around this vulva. Vulvodynia is there. Might be the vestibulitis is there, inflammation of the vestibular area. If that is inflamed, swelling is there, you cannot go inside the vagina. So that can be the reason of your vaginismus. But that will be the temporary reason. Okay, so as soon as the inflammation will be gone, so you can penetrate inside the vagina. Difficult childbirth. Now, last time you had a childbirth, and then you don't want to get pregnant again, and there was too much of pain during the healing process, too much of laceration, difficult labor. So that can be a reason why your muscles got a lot of the tearing or incisions, and because of tearing incisions, there might be the scarring, adhesion, and shortening around the vaginal area. The bulbocavernosis muscle fibers are shortened, and they have the tension, more tension, spasm, adhesions, scar tissue form there. So that might not let you to go inside the vagina. So this kind of things which we are calling it as a secondary vaginismus, not a primary. Primary means you never penetrated inside the vagina. Secondary means you used to penetrate inside before, but now it is difficult for you after the childbirth or after this episiotomy and perineal tears, or those scarring and so those incisions over the perineal body, or any accidental damage to that area where you had to go for the stitches. So that can be one reason. Or there might be you cannot penetrate inside the vagina because you have a lot of dryness going on, side effect of certain medications which is lowering your estrogen effect. You might keep taking a lot of contraceptive pills when you don't want your eggs to develop, and that pills, this birth control pills, they will always reduce the effect of estrogen level. The lubrication will be always less in those cases. So if it can be the reason of the creating the dryness around your vaginal area, and due to dryness, your muscles are not smooth and relaxed. The smooth muscles and orifice, they are not kind of moisture, and when you are trying to insert, dryness is there, you can't go inside. So that can be the secondary reason. So vaginismus when we are saying is, so it is mostly when we are talking is you cannot go inside, the door is closed, outer door is closed, and outer doors can be closed because of the pelvic floor, or outer doors can be closed because of other factors also. And specifically when we're talking about vaginismus, primary vaginismus, so in this case, pelvic floor, or the spasm of the pelvic floor muscle is the culprit. Shortening of the pelvic floor muscles, scarring, adhesion of the pelvic floor muscles can be the main culprit. 90% we would say that like permanent vaginismus. Okay, they are trying from last 1 year to penetrate inside the vagina. Last 3 months, there is no infection, but still they cannot penetrate. So that is a vaginismus. It means spasm or tension into the pelvic floor muscles. Door is closed. Once the penetration is possible, but the penetration is painful, so it means the outer door is open, might be halfway open. Some muscles are relaxed. Bulbocavernosus might be relaxed, but the pubovaginalis is not relaxed, or the levator ani is not relaxed. Some muscles are not relaxed, or not only the muscle, some internal pathology is there. Some inflammation is going on into the vagina. So as soon as you are trying to insert, your smooth muscles are inflamed. You are having pain during the sexual activity. Might be your organs are stuck inside. The endometriosis is going on. Interstitial cystitis is going on. They are causing you pain. So dyspareunia is pain during sex, and that pain can be because of the visceral pathology. That can be because of your your canals pathology, or it can be because of your infections as well as the pelvic floor muscles. But in case of dyspareunia, mostly that superficial muscles are not that much tight. Mostly the deeper layer of the pelvic floor are more culprit. And causes of vaginismus and dyspareunia can be anything: tight pelvic floor, or tight structure, or scarring, adhesion into the structures, outside or inside. Negative sexual attitude. I don't want to have sex. So if I don't want to have sex, sex is bad. So I'm not taking it positively. That is automatically gonna increase the tone of my pelvic floor. So I'll close the door. So I'm not ready to have sex. Sexual or physical abuse in childhood, or anytime whenever the forceful sex is going on, sexual abuse is there, our body don't like it, our brain don't like it. Once our brain don't like it, it don't give a signal to the body. Brain doesn't like this sexual abuse. So now it's not a good feeling. I don't want to have it again. Okay, so close the door. So body itself will create a guarding effect. Whole body will be tight and tensed, and more tension will be into the central part, pelvic floor. That will be the reason of that, which is more 90% the vaginismus. The reason of the vaginismus is the sexual or physical abuse I found in my practice. Psychological or physical trauma, where the adhesion and psychological means that how you are perceiving this area. Oh, that is a wrong, bad area. So you're creating that tension. Or might be psychologically, you have this like, okay, let me play the game, let me hold my urine, let me hold my feces. You are having holding habits, habitual pattern is there. So your brain is trained into that way. The next time you will have the sensation, your muscle will go for tension, not releasing. So that is a wrong training your body got. That can be one reason. Relationship difficulty, when we don't have a good relationship with the partner. So I'm not having a good chemistry with my husband, or might be if he'll come close to me, he'll start having sex. I don't want to have sex because of this. The fight is going on, chemistry is not there. So might be my whole body will not react in the way it should be reacting, and peripheral muscles will start getting closing or spasmodic due to that brain, what the brain is sending signal to the body. Or negative views about sexuality. can be there. Might be she might have saw some kind of pictures, some kind of graphics, or some kind of moments which she didn't like it, or so she don't want to experience it, or someone might have just told him that sex is painful. So if the sex is painful, I don't want to have sex. So I don't want to involve into that. So that can be a reason of creating that kind of guarding around the pelvic floor, or creating the tension around the pelvic floor, or tension into other cases, like she has a very tense core, very tight core is there, or she might have she's doing a lot of exercises like plank workout, or when she created the tension into tightness into the whole core muscles, and she has back pain issues going on, a lot of back pain issues are going on, or might be adhesions are going on around the pelvic region, pelvic pain are there, chronic pelvic pains are there, endometriosis are there. So those kind of issues can be also a reason of dyspareunia and vaginismus. Your fascia can get trapped into those cases. So vaginismus, dyspareunia,
So ideally, the reasons for both the conditions are same.
same. But depending upon which structures are outer superficial door is itself, like no, always there's a door. You are penetrating inside. You want to come inside this room. If you want to come inside the room, first you have to come in this house now. First you have to open up the door of my house first, the main gate. But in the female, the main gate will not open. Means the brain will not open. So brain will not accept. So the first is the psychologically, is she's ready or not for this activity, for penetration. If your patient is coming to you and she's okay, fine, everything is fine, but as soon as you are telling her that in pelvic floor examination, we have to go for transvaginal and translateral. Oh, no, I don't want to go for penetration. So means brain don't want to, her brain is not letting her to have your finger inside her vagina. So means you cannot penetrate inside we don't know what is the muscles are relaxed and tense, but she don't want you to penetrate inside the vagina. So in this case, we cannot say that she's suffering from vaginismus, but she don't want you to go inside the vagina at that particular time period. But then we have to tell her, okay, so if you don't want me to insert my finger, can you insert your finger? I want to see that what is the status down. Can you insert your own finger inside? No, I don't want to insert today. Okay, are you inserting tampons? Are you involved in sexual activities? Are you involved in inserting any menstrual cup inside? Yes, if the penetration is there, so it means it is not vaginismus. She's doing it. It's just today she don't want to go for any this kind of penetration. So female, the brain is the first thing. And if the brain is telling her, okay, I'm ready, you can penetrate. And she's allowing you to penetrate, and then you cannot go inside. You're touching the vulva, and as soon as you started, then you are asking her to abduct. You are go and stay in that position, which is that examination position. As soon as she's going to the position, she's hesitant, or she's trying to open up, but her adductors are very tight. So she cannot go into this complete external rotation because of the tightness all around the pelvic region. So means the door is closed. So if that tightness will be into the this second outer gate. First was is she able to lie down? Is she's ready for that? So not ready, okay. So then we will stop. We cannot go for penetration. And if she's ready, but her adductors are tight, so second problem. And if adductors are okay, she's ready, she's relaxed. As soon as you go near and you touch the vulva, I have pain, vulvodynia can be there. So you cannot go for vaginal, that can be, you cannot go for penetration. Okay, vulvodynia is not there. Okay, you will start opening up. Vestibulitis is there. So you cannot go inside. And vestibulitis is also not there. Then, if you cannot go inside, it means the bulbocavernosus muscles are tight. And that is the vaginismus actually. When your bulbocavernosus muscle, your pelvic floor muscles are having tension, shortening, spasm, they will go for spasm, okay? Or some scarring is there. The door is closed. She's ready, but the door is closed. This female is ready, her body is aroused, desire of sex is there, she's aroused, she wants to have penetration, lubrication is also there. But as soon as the penis is coming, the muscle is going for spasm, suddenly closing is there. hypertonous pelvic floor can be there, or structures are very, very tight, so they cannot penetrate. So this is when you cannot penetrate inside the vagina, she's ready. This is vaginismus. And once she can penetrate, and it's pain, you can go, but it's pain. So penetration is going on, but not a smooth penetration. As per that, I have designed one scale for that. So how to assess your patient, like where your patient is there is -1, -2, -3, -4, -5. So we have designed scale. When the brain is involved, she don't want to go for examination transvaginal or transrectal. Might be the virginity issue is there, okay, or might be the shame. She don't want to open up. She don't want to just remove the clothes. So when the mind is involved, we are calling it as -1. You cannot go for penetration. We cannot palpate. When you cannot palpate, we are not talking about that transvaginal, transrectal approach. The approach will be crossed now. She's not accepting you. Then do whatever you can do externally. And the second is when she's accepting you, the brain is okay and brain is giving signal to the body, but body is not relaxed. So that is -2. Superficial doors are not open up. Pelvic floor muscles are not relaxed. -2. When the superficial muscles are relaxed, and then the bulbocavernous is relaxed and you are penetrating, and then she's having pain during the penetration, means deeper structures are not relaxed. So that is -3. So once you can penetrate, the pubovaginis is also relaxed, bulbo is also relaxed, you are inside the vagina. But inside the vagina, as soon as you started touching the organs, the clitoris, the G-spot, or the bladder, or the cervix, or the uterus, or the side muscles, as soon as you started touching, she has internal pain. Then she said, oh, pain was not there in penetration. Pain is there when you are touching something inside. So that is -4. The patient is having pain, deeper pain. And when you insert your finger, you do everything, you touch everywhere, you palpated all the muscles, and you came out, you inserted 2 fingers, you came out, you inserted 3 fingers, you came out, no pain at all. So this female is -5 out of -5. Complete relaxation is there. So this way, -1, -2, -3, -5. So where your patient, what is the status of your patient, which scale she's lying on, according to that, our treatment protocol will be there. If -1 is there, so this patient requires a lot of education, psychological education, understanding of this, why we have to check the muscles. So a lot of understanding about the pelvic floor muscles, her problem, she has to understand her problem, sexual functioning, vaginal functioning, what is vulva, what is bulbocavernous, what is these muscles, everything, education, counseling is more focused. We'll try to make her brain to accept the treatment. So counseling will work in those cases where the brain is not accepting. Oh, I don't want to have sex. So then we have to give her a lot of education about the good sex and the importance of sex in the life, female sexual functioning, what is normal, what is not normal. So counseling will come into -1. And if it is -2, and this is what the mistake doctors are doing, gynecologists, sexologists, this is the one mistake they are doing. In case of vaginismus, they're only focusing on to counseling. They don't know where your patient is lying. If the patient is lying on -2, it means she's already accepting now that she wants to have sex. But she cannot have sex because of this problem going on around the physiology, around the muscles, around the structures. So this female either needs some medications to recover the infection, if the infection is there, or relaxation of the pelvic floor muscles, or the tightness, release the tension of the adductors, or the stretching exercises, lot of stretching exercises to relax those downward parts. The pelvic region might be whole pelvic bone is tight. So we need to release that piriformis, we need to release the iliopsoas, we need to release that adductors, obturator internus, whole palpation around the pubic symphysis, deeper abdominal muscles we have to relax. And we have to relax the coccygeal muscles, sacral muscles, we have to relax the ischial muscles, and then we will go towards the pelvic floor. We'll relax the pelvic floor muscles, bulbocavernosus, superficial transverse perineum. They are not releasing those muscles, they are only telling her, okay, penetrate. So it's okay, apply force. First time it can be the painful, but you have to have sex. But I cannot have sex. My muscles are having tension. They are having spasm. I have a different tight structures down there. My whole body is having myotonia or tension in the whole, like those kind of tense structures around the hips. So that's how they failed in treating the vaginismus. They cannot treat vaginismus. So if they cannot, they are only giving the counseling to the female. Have sex, have sex, have sex. Take it positively. Love your husband. You are not loving your husband. You cannot see his pain. Oh, I'm looking at his pain, but look at my pain also. I'm ready to have sex, but my body is going for spasm, sudden spasm. So what this patient requires, psychological counseling or the relaxation of the muscles?
Relaxation of muscles.
There where they fail, and they fail to relax the muscles, and then they are ended up into like IVF. The baby at last couple wants to get pregnant, but they cannot get pregnant because penetration is not going on. So I want to have pregnancy. I don't want to have sex because now I'm failed from 1 year, 2 year, 3 year, 10 year, 14 year. I have a patient going on who is 44 years now. She's the patient I'm treating from Hyderabad. She's from the Hyderabad. I'm giving her online sessions, and I have a trained therapist in Hyderabad. So she's taking session from her also. So this patient is 44 years old, and she got married when she was 26 years old. So you can say that 18 years of marriage, never had sex. And they tried IVF many times and it was failed. And this is now she really want to just relax the pelvic floor. And you will not believe, it's like we finished. We are just about to finish a treatment. It's already finished. So it's like, I think I don't remember, around 34 sessions has finished, and her pelvic floor muscles are relaxed. So 34 session means within 40 days. And the suffering was 18 years suffering. And what we treated is only 14 days of pelvic rehab therapist and relaxed pelvic floor muscles. And now they are having this kind of, we are inserting the dilators, and dilator size 3 is going on. Very soon it will be 4 size, 5 size, and 6 size also, and relaxed pelvic floor. So seriously, I have many females in my life where I have given the successful pregnancies to them without any IVF, just to have sex and the sperm will go inside. You can change that life of a female, like 9 years of suffering, 14 years of suffering, 18 years of suffering, many long. Now I'm treating one patient. I just started treating her. She's from New Jersey. So I just started treating her. Only 4th session has gone. And she's married since 7 years, never had sex. So now, we'll always 100%. Our result is 100%. It's not 99%. Our result is 100% sexual intercourse we're going to give her. So this is the vaginismus. And sometimes if you're having painful sex, pain during the penetration is a dyspareunia. Pain during the thirsting moment or inside during examination, palpation, thirsting. So that is -5. And this is how the scales are designed. We will discuss about the scale tomorrow. Today, we are just trying to understand the conditions. So this is dyspareunia and vaginismus, where your muscles or internal structures can be tight, and we have to release them, relax them.
So, Dr. Patel, I know we will be discussing tomorrow, but I didn't understand the grade 3. So you said -1 when she's not ready. Second is when she's accepting sex, but she can't because of the spasm. So -3 was what? Pain during penetration.
Was that superficial muscles are relaxed, but the deeper pubovaginous muscle is tight.
Okay.
Or the other muscle like ureterovaginous muscles, the deeper muscles are tight around the orifice. It's like a tunnel. So you cannot go inside the tunnel. Tunnel is tight. So might be tissues are tight down there. You're inserting your finger, and female pain during the penetration. So when you are penetrating, she's having pain, discomfort, tightness. Those kind of 3 symptoms.
That is -3. And then if we went into the deeper level.
Yes. So it means
And
penetration happened.
Yeah.
Penetration happened without any pain. Penetration happened. So no pain. So means she's not -3. But now as soon as you inserted your finger inside and you started palpating the internal organs, pain is there because around the cervix, pain is around that uterus, pain is around the bladder, pain is around the rectum, pain is around the sideways levator ani muscles, iliococcygeal muscle. So pain is into the coccygeal muscle, pain is into the all this all the ligaments which is supporting that area. So internal pain into the organ or into the levator ani, iliococcygeus, or it can be the coccygeal muscle, they are painful. The sidewise muscles are having some kind of tensions. So means the sphincteric muscles are relaxed, but the supporting muscles have some kind of tension inside, internal tension. So that can be the reason. That is -4. Once there is no pain at all, you inserted your finger, palpated everything, checked everything, checked the muscle strength into the center, on the sides. You palpated, spent time also inside. Palpated 1 time, 2 time, 3 time, no pain at all. Are you okay? Okay, I'm okay. So she's okay, no pain at all. And you're applying pressure from the abdominal also, biomanual examination, still no pain. So no tension, no pain, no pressure, no tenderness, everything is fine. I don't have any pain. So this female is relaxed female. So this female you can go for, you can proceed ahead with your, now you can check how good the pelvic floor muscle is, how good this, how much is the strength. Can you check the strength of your pelvic floor by inserting your finger without testing the relaxation scale?
No.
No. This is the one mistake the whole world pelvic rehab therapists are doing. You will not believe there is no scale of for the pelvic floor to check the relaxation capacity, how relaxed the muscles are. They are always telling, today what you'll do, go to the Google and try to find out scales for pelvic floor muscle, testing scale to test pelvic floor muscle, and tell me, let me just put that name onto the group, which scales you found out and how to check the strength. Each and every scale, like, okay, this is your homework. Do this and please find out, try to look for the scales to check the pelvic floor muscle and put that in the group. Let's have this discussion today. Okay. Other causes of this, other conditions can be there, pelvic dyssynergia. Pelvic dyssynergia means the muscles in your pelvic floor become uncoordinated. It can be over tight puborectalis muscles. Pelvic dyssynergia. These muscles which is holding the rectum, they are too much tight rectum. They are keep holding it anteriorly. This happens because of wrong voiding habits or habitual pattern. When the body is sending you the signal that go and pass the stool, but you are not passing the stool, and the body will be incoordinated in those cases. Body is telling you go and pass urine, but you are holding the urine for a long time. So your muscles will be incoordinated. They will fail to note down that when they have to relax and when they have to contract. So now next time, whenever pressure will fall, and then you train your muscles in that way, the next time pressure will come, they will go for contractions. So this will make your passage too close. So the complete blockage of the outlet can be there in this case, and difficulty to pass the stool in coordinated pelvic floor. Passage of stool can be even incomplete or very, very too much of voiding pressure, and small urine come out, a small stool will come out. So tight pelvic floor, pelvic dyssynergia we are calling it, when pelvic floor will become incoordinated. Levator ani will become incoordinated, specifically levator ani. Pubourethralis, puborectalis. We also call it as a pelvic dyssynergia as puborectalis syndrome. So this is again specifically only the puborectalis muscle is getting tightness. So occurs when the muscle don't know how to relax, when one bear down to pass the stool. So whenever we are passing the stool, muscle has to go for relaxation. But instead of relaxation, they are incoordinated and they are creating contractions. Again, the habitual pattern is responsible for this. So we are calling it as a puborectalis syndrome. Puborectalis muscles is getting sudden spasm when you want to defecate. Like a vaginismus. Vaginismus is like spasm of bulbocavernosus when you want to penetrate inside the vagina. And same way, puborectalis syndrome is a spasm of the puborectalis muscle. So a client wants to pass the stool, but suddenly the pelvic muscles will go for, puborectalis muscle will go for spasm. Coccydynia is another case, another condition which refers to any type of persistent tailbone, and that can also have a effect onto the pelvic floor muscle because of the tension going tight back muscles, low doses posture, It can be because of very loose muscles down there, pelvic floor muscles. They will not pull the this coccyx anteriorly. That stability is not there. So that can be the cause of this internal uterosacral ligament are tight. That can be the reason of coccydynia. Okay. Coccygeal muscles are tight. They can be the reason tight and very loose, sorry, not tight, very loose. So coccydynia is not coccydynia is a painful situation, but it is because of the tension of the back muscle, but low doses. But this is not because of the tight pelvic floor. It is because of the weak pelvic floor actually, when the stability will not be maintained. Yeah, we discussed about urinary incontinence. We also discussed yesterday about vaginal laxity. Vaginal laxity happens once the rugae got flattened and too much of lax vagina is there. Smooth muscle itself gets saggy. They don't lose its tone. So that is the vaginal laxity. And that happens because of the multiple vaginal childbirth, poor repair from those deliveries, prolonged labor stage 2 when the baby stuck there for longer time period, history of prolonged sexual activities, multiple sexual partners, sexual traumas, certain medical conditions, which is creating the estrogen hormonal effects, aging factor, or what is the symptom of the vaginal laxity? 75% of female, they suffer from vaginal laxity. Loss of friction inside the vagina. So they cannot feel anything. Or we can understand that why they are not feeling, because that sensory nerves are not that strong. They're only present at the lower 1/3, but at least at the lower 1/3 there should be sensation, feeling of the sensation. But the tone is lack of the tone. So no grasping is there. So because of no grasping, inability to hold the things, or decreased ability to experience orgasm, and even lower sexual satisfaction. When something will go inside 1 finger, 2 finger, 3 finger, they will not feel it because of the laxity sagging. So that can be, this is the vaginal laxity. And if you strengthen the pelvic floor muscle down there, so you can help your patient in grabbing, creating this feeling of grasping and sensation and proprioception being back. Again, other is the pelvic organ prolapse. So let me stop here and we will discuss about pelvic. You can just take a screenshot. You already understood that pelvic organ prolapse means falling out of your pelvic organs from your vagina or from your rectum downwards. Okay. In case of male, the things can fall out from the rectum. In case of female, even in case of female also, things can fall from the rectum. Like uterus can fall out from the rectum, that filling inside the rectal area. So things will not be out from the anus, it will be into the rectum. Uterus can be into the rectum, into the anal rectal region. So we have this type of prolapse, cystocele, when your bladder is falling down by putting pressure over the anterior wall of the vagina. Then it can be the cystocele. We call it as a cystocele. And second can be the rectocele, when your rectum is falling out from your vagina by putting pressure over the posterior wall of the vagina. It can be your uterocele, when uterus is falling downwards. It can be your intestines after hysterectomy, when uterus is not there, the area will be complete empty, and might be it will put pressure over the vagina and the upper part and the rectal. This intestines can start falling out. So we are calling it as a enterocele, E-N-T-E-R-O, enterocele. And it can be vagina can start falling outside. So vaginal vault prolapse can be also there. So I would request you, please take a screenshot of this one and read it. It's easy to understand what the patient will feel. As what kind of symptoms will be there in case of cystocele, in case of rectocele. Take a screenshot. We will discuss it tomorrow. What is the difference between piles and fissures and fistula? We will discuss tomorrow. And then we'll start assessment.
Can you go back 2 slides? I couldn't take the before this one. No, the next one. Yes.
All right.
I'm writing the points all the time. So my hands after, these 3 hours, they literally hurt and my back. I start feeling like I'm in the college and,
Oh.
just like we used to study in masters, like 10 hours, 8 to 10 hours we used to study, sitting at one place. And then we used to practice yoga nidra and all that because we couldn't get, even if your body, you would feel sleepy, but you cannot sleep, because your mind is so active.
That's good, no? That kind of thing is coming back. It means you are more deep into this learning.
You won't believe, yesterday I was sleeping and in the middle of night I got up because I had to pee. So even at that time I was, that endometriosis topic was going on in my brain because before sleeping I was reading it. And in the morning also my eyes were literally hurting. And then, but I thought that no, she sent these and we I have to, read it
Yeah,
at
go
least.
through it.
So I just went through the YouTube video of endometriosis only because I already slept at one yesterday. So I couldn't saw the other video so far.
Means
Yeah.
like you are enjoying it.
Oh, of course, of course. I'm loving it.
Love it. This is what I
Yeah.
need from all of you actually.
I have actually created almost, a full, so many notes. It's like a book now.
Wow, that's good.
I mean, I have the screenshots, like I'm taking screens. When I write my own thing, then it's like it's going in your brain, right? I might not be even reading those. I don't know.